Hanji, very good evening, everybody. Good evening. So I'm very happy to be back today, and we will discuss another topic of radiology, which is going to be slightly more complicated but more interesting, which is called as MRI. MRI gives us more information. We are able to see lot more anatomy on MRI than CT. So if you enjoyed the CT scans session, I'm sure you will love the MRI session as well. So my goal now will be to talk about MRI and give you the basics. I will give you the physics and then I'll take you to the images. That is my target for today. Okay, everybody, good evening, everybody, good evening. Okay, so let us look at two aspects of radiology. Okay, we have to first see the why behind MRI, that how MRI really works. Then I will shift over to how to identify the images, and then I will show you the basics and advances in MRI. And by the end of my class, we should be able to even apply it in clinical situations today. So my goal is to start with basics, I will go on to So I can see some students who are joining the class today for the first time. Don't worry. In the previous class, we talked about CT. This class, we are going to talk about MRI. They are two different investigations. Don't worry. You can, catch up from here and then go home and see the previous video again. So let's start. Let's start. Okay. Okay. First question. Let us start with the first question today. Okay. What is MRI based on? What is the principle of MRI? Okay. Okay, first one. Okay, everybody, what is the principle of MRI? Please see, this is how a MRI machine looks like. I know the shirt Dr. Deepthi has selected. Thank you to Dr. Deepthi. Now start. Okay, so this is how a MRI machine looks like. First question, what exactly is MRI? This machine is a magnet. This machine is a magnet. So, first question that has been asked many times in the past. Now they are asking more clinical things. But earlier they have asked, what is the magnetic field strength of MRI machine? If you know it, please let me know in the chat box. What is the magnetic field strength of MRI machine? Usually it is around 1.5 Tesla. Okay, 1.5 Tesla, which is much more than the Earth's magnetic field. Which is much more than the Earth's magnetic field. And you can imagine now that once in the 2017-18 NEET PG, they asked a question like this. MRI machine has a magnetic field strength less than the Earth, more than the Earth. The answer is more than the Earth. Much more than it is a very strong magnet, much more stronger than the magnetic field of the Earth. Okay, Apurva, we've just started. This is the first diagram I have drawn. MRI machine is a magnet which has a magnetic field strength of 1.5 Tesla. Now, let us now put the patient into it. In the MRI machine, the patient goes like this. Okay, so patient goes into the magnet. Patient goes inside it. So, what if somebody has claustrophobia? What if somebody has claustrophobia? Okay? Or what if somebody has a cardiac pacemaker? What do you think? Now, because we are in a magnetic field, pacemakers can, stop working, and somebody who is afraid of closed places can go into a panic attack. These are all relative contraindications to MRI. Relative contraindication. Everybody, relative contraindication, not absolute. Absolute kyun nahi hai? Because, listen to me everybody, now modern pacemakers have been made which are MRI friendly. Now there are pacemakers available in the market which are MRI friendly. So what is one absolute contraindication to MRI? What is one absolute contraindication to MRI? This is a question that was asked in INI CT recently. Anybody wants to tell me? What is one reason in which you will never do an MRI? One absolute contraindication. Anybody remembers? Ferromagnetic foreign body in the eye. Yes, Soumya got it right. Very good. So if you have a suspected ferromagnetic foreign body in the eye, if the magnet will pull the foreign body, it will cause more damage. That is an absolute contraindication to MRI. Clear, everybody? Sakshi also got it right. Sadhana and Sangeeta, Abhishek, very good. Okay. So one absolute contraindication is this: relative claustrophobia, cardiac pacemakers, even cardiac valves. Now, you should now know that the modern valves are MRI friendly. Older valves were metallic, but now the modern valves cardiac valves that are prosthetic valves that are used now are MRI friendly. So we can say relative contraindication depends on the variety of valves. Okay. Nilesh, you understand? Relative contraindication. Matlab, if you give him Nilesh, if you give patient sedation, you can actually do a MRI even in a claustrophobic patient. So it is not an absolute contraindication. Okay. So with this discussion, let's go backwards. Okay. Everybody, are you clear? Everybody clear? Now, what I will do is, now I will remove it. I will remove all this and I will ask you the second question. First question was MRI has a magnet which is much more stronger than the Earth's magnetic field. So in our human body, everybody listen to me. Everybody listen to me. I want you to answer in the chat box. Don't talk to each other, talk to me. Okay. What is present in our human body? Hamare body mein, what is the magnet? What is present in our human body which will interact with the magnetic field of the MRI machine? In our body, we have hydrogen ions. We have hydrogen ions which are magnetic. They behave like a dipole and they are abundantly present in our body. That means they are in plenty. You have a lot of hydrogen ions in our body and they will react with the magnetic field. And I think Abhishek, Soumya, Ankita, Prachi, Nisha, Sarthak, everybody got it right. Now tell me. Now everybody listen to me. Right now I am standing in front of you and the hydrogen ions in my body will be randomly aligned. But what about this patient? What about this patient? Tell me. He is inside a magnet. What will happen? If you are inside a magnet, your hydrogen ions get aligned along the axis of the machine. Do you remember? Magnetism is a vector. It has a direction. So if you take a patient into the MRI machine, the hydrogen ions in his body get aligned. Clear? Everybody clear? Okay. Now, Shailesh, I am repeating again. Shailesh, एक बार सुनते हैं. Olden times में we were using metallic cardiac prosthetic valves, which were contraindication to MRI. Nowadays we use bioprosthetic material, which is safe in MRI. That is what I said. Okay. Are you clear? And Ankita is saying, sir, why intraocular foreign body? Why not any other foreign body? Try to understand, Ankita. If you have a foreign body inside your shoulder muscle, maybe it will move a little bit, but in the eye, if it moves a little bit, it will cause retinal damage, more damage. So this is having a closely packed organ with lot of sensitive structures which can be damaged by the movement of the metal. Clear? Clear, everybody? Okay. Now, so in between, I'll keep answering your doubts. Don't worry. Now tell me, my question is, have you ever seen inside the MRI machine, you will hear some noise. That noise is due to application of a RF pulse, which is, RF is short form for radio frequency. So in MRI machine, when the patient is inside the machine, whatever part we want to see, suppose I want to take a section of this area. Suppose I want to take a section of this area. In this particular area, I will apply a radio frequency pulse at different angles. Okay. Now, so try and imagine what is going to happen. And I want all of you all of you to listen to me. It is very difficult concept, but once you follow it, it will form the basic of what we will do later on. Suppose this is a hydrogen ion. Suppose this is a hydrogen ion in a magnetic field, at a steady state in a magnetic field, and you apply a radio frequency pulse. Okay. Okay, one bacha has asked again and again, Rimi has asked ki sir, orthopedic implant mein kya hoga? So Rimi beta, nowadays most of the orthopedic implants are made up of titanium and they are MRI safe. They are MRI friendly. So you will never mark orthopedic implant as absolute contraindication. And most of the orthopedic implants are safe in MRI. Okay. Now everybody listen to me. Now clear? So suppose this is an hydrogen ion and I am applying a radio frequency pulse. When I apply the pulse, hydrogen ion will change the position. When you apply the radio frequency pulse, hydrogen ion will change the position. Now suppose I switch off the RF pulse, what will happen? Suppose I switch off the RF pulse, what will happen? Anybody? Anybody? The hydrogen ion will relax and come back to the original position. Hydrogen ion will relax and come back to the original position. This is called as longitudinal relaxation. This is called as longitudinal relaxation. Okay, everybody clear? Now tell me, any one of you can answer my question. Any one of you can answer my question, beta. Okay? How long? Okay, everybody, listen to me. Listen to me. Stop typing. Listen to me. If in a MRI machine you apply a radio frequency pulse and you switch it off, how long does it take for the tissue to show longitudinal relaxation? What is the time taken to show the longitudinal relaxation? This time is called as T1. This time is called as T1. And if we make a image, it is very complicated. Listen to me, bacha. If we make a MRI image based on T1 time, it is called as T1 weighted image. Okay, it is called as T1 weighted image. I am repeating, everybody listen to me. Okay, एक बार ये लिख लो और मेरी बात सुनो. देखो. So what is happening is, in our body we have different tissues. If we apply a pulse, radio frequency pulse, different tissues, hydrogen ions will relax at different speed. This is called as longitudinal relaxation. Every tissue will have different T1 time based on how fast they can recover after the magnetic pulse has been applied. That is called as T1 weighted image. Now look at the second part. Look at the second part. Everybody, look at the second part. Suppose this is the hydrogen ion. Hydrogen ions, like any subatomic particle, are not static. They are not static. They are spinning. Hydrogen ions are not only moving, they are spinning. So when we apply a RF pulse, everybody listen to me first. When we apply an RF pulse, the spinning axis of hydrogen ion changes. The spinning axis changes. Now if I switch off the RF pulse, what will happen? If I switch off the RF pulse, what will happen? Anybody can tell me now. If I switch off the RF pulse, what will happen? The hydrogen ions will recover the spin. This is called as transverse relaxation. Okay, this is called as transverse relaxation, and it happens in a time T2. So every tissue, transverse relaxation will take its own time, but depending on the type of tissue, and that is called as T2. MRI images based on T2 time are called as T2 weighted images. MRI images based on transverse relaxation are called as T2 weighted images. Clear? Everybody understands? So I'm zooming out. I'm just showing you the slide. This is all what we have done so far. Okay. MRI machine. Okay. MRI machine is a magnet. You put the, okay. Now, those of you who could not understand, Aviral Sharma and everybody, listen to me again. एक बार pen छोड़ देते हैं. Everybody, leave the pen. Okay. Leave the, keep the phone slightly away and listen to me. Okay. मैं जो कह रहा हूँ सुनते हैं. Okay. Now, what is happening is you take the patient, you put the patient into an MRI machine. Okay. Now, when I go into the MRI machine, my hydrogen ions will become aligned along the direction of the magnetic field, Then in the area I want to see, I will apply a radio frequency pulse. Some of the bachas were saying, what is radio frequency pulse? Radio frequency pulse is a short-lived magnetic field. So we are applying a magnetic pulse, radio frequency pulse. Now what will happen is, every tissue, it is known in physics, when you apply a short-lived magnetic pulse on a proton which is in a steady magnetic field, it will get disturbed, and when we switch off the pulse, it will relax. But what is happening is two type of relaxations will happen. Hydrogen ions will come back to the original position, which is called as longitudinal relaxation. Hydrogen ions will recover their spin, which is called as transverse relaxation. Okay? Are you clear? Now, एक बच्चा कह रहे सर हर टिश्यू में हाइड्रोजन तो है तो सबका सेम क्यों नहीं है ट्रांसवर्स लॉन्गिट्यूडनल रिलैक्सेशन? आई थिंक हिमांशु इज सेइंग. So Himanshu, please try to understand. Our body has hydrogen ions, but it is not purely hydrogen. It is made up of complex carbon lattice. So muscle will have a different lattice structure than bone. Bone will be different from maybe liver. So every tissue will have its own complex 3D lattice structure, which affects the hydrogen ion relaxation. Okay. Now, everybody clear? Now my question to you is this. Let's try to understand so that we are able to solve it when we see the image. Now, that means in MRI there are two type of images, T1 weighted, T2 weighted. But how will we produce these images? That means while doing MRI, all we are doing is we are applying RF pulse, we are applying radio frequency pulses. Okay. Now, suppose I apply a radio frequency pulse for a duration, listen to me everybody, for a duration TE. That means the pulse is on for a duration called as TE, which is the short form for echo time. And then I repeat the pulse after an interval of TR. After an interval of TR, which is nothing but repetition time. Okay? Are you clear? So I hope you are able to understand. Every tissue will show both kind of relaxations, T1 and T2. But I want that at one time in my image, one type of relaxation should predominate, because I want to produce either T1 weighted image or T2 weighted image. So try to understand. Very important. Listen to me without asking right now. First listen to me, bache. See, if I apply a short duration RF pulse, TE is short, and repeat at short intervals, that means I am applying like this. Are you clear now? Abhishek, we just started in, I think, 5-10 minutes. Listen to me, bache, dekho. So suppose I apply short duration RF pulse at short intervals, that means TE is short, TR is short. The tissue will produce predominantly T1 weighted image. The MRI image will become T1 weighted. If I apply a long duration RF pulse and give a long gap in between, it gives time for hydrogen ions to show the spin relaxation. So what happens is, if TE and TR both are long, spin relaxation starts to predominate and the image becomes T2 weighted. Are you clear? Everybody understands? Okay. So we've just done one page, we're just repeating it. Now I'm again repeating to all of you. Please try to understand. Very, very interesting thing. I could have skipped it, but I want to make sure that we start from the basics and then go upwards. Okay. Please see. I'm again repeating. MRI images are obtained when the patient is inside the MRI machine and you apply a radio frequency pulses to that area to disturb the hydrogen ion. But whenever we switch off the hydrogen ion, whenever we switch off the RF pulse, the hydrogen ion will relax. If you give less time to recover, if it is a short pulse with less time to recover, the T1 weighting or the longitudinal relaxation predominates. If we give more time, that means T is long, TR is long, transverse relaxation predominates and the image becomes T2 weighted. Okay, everybody follows? Are you clear? Okay. Now, once you are clear, what I am going to do is, this is just to make sure that we have some background information going on in our mind. Our goal is to look at the images. But before we look at the images, I want you to draw a table. This one table contributes to one question every year in the exam. Okay. On MRI, there are T1 weighted images, T2 weighted images. And the question is, what is the appearance of CSF on MRI? Okay. Anybody? What is the appearance of CSF on MRI? Anybody? CSF, we all need to remember, will appear dark on T1 weighted image, white on T2 weighted image. CSF appears dark on T1 weighted image, white on T2 weighted image. We will make it technically by saying hypo intense on T1 weighted image, hyper intense on T2 weighted image. Okay, I want all of you to understand. सुनो मेरी बात. जैसे if you remember in CT, I was using the term dense. CT में I was saying hypodense, hyperdense. MRI, I am using a term hypo-intense for dark, hyper-intense for bright. Okay. Now, I can also say low signal instead of dark, high signal instead of white. So what happens is, this is the language of radiology. Sometimes you get confused if you are not used to it. These are all same. That CSF is dark on T1, low signal on T1, hypo intense on T1. These are all synonyms. Same meaning. Okay. Now Rishabh is saying, sir, echo beta sound होता है, तो वो हम अल्ट्रासाउंड में बात करेंगे. Rishabh will talk about that in ultrasound. Clear? Okay. Now second question. So I want all of you to first make this table, then I will take your queries. So let us write down this table because it is very important, very often repeated. Fat appears white on T1 weighted image, less white on T2 weighted image. Okay. Now some bachas are saying, sir, when will we read thoracic anatomy or abdomen anatomy? I will teach you everything. I have separate sections for everything. Don't worry. I will talk about everything subsequently. Don't worry. Okay. Just believe that everything will be covered in the class. Only listen to the class. Okay. Now, in one of the NEET exams, they gave a questions. Which substance appears hyper intense on both T1 and T2 weighted image? Which substance is white on both T1 and T2 weighted image? What is the answer? Fat. What is the answer? Fat. Okay, let's see one more question. What about cortical bone, calcium, air? Always remember, on MRI, cortical bone, calcium, air are dark on both T1 and T2 weighted images. Okay, are dark on both T1 and T2 weighted images. Now I want all of you, I can see all of you are able to answer also. Listen to me and answer. What was the color of bone and calcium on CT? Calcium or bone CT पे कैसा था? Cortex कैसा था? It was white. On a CT it was white. On MRI, cortical bone and calcium are dark on both T1 and T2 weighted image. Air, dark. In addition to these, in MRI we also need to know things like fibrous tissue, which could be tendon, ligament, okay, tendon, ligament, meniscus, okay, anything which would have some fibrous component will also be dark on both T1 and T2 weighted images. Anything which will have hemosiderin, or if you have flowing blood in the blood vessels, they will appear dark on both T1 and T2 weighted images. Okay, it is, I know it is slightly difficult, but very very important. I know some of you might be saying कि sir इन सब का भी कारण जानते हैं इसमें, if we go into the reasoning it will go too long and it is going to defeat the purpose of getting it crisp. This is the only thing you need to remember. Okay, I will just remove myself so that you can see the table clearly. This is what you need to remember to be able to evaluate MRIs. Please see everybody, this is one table, you can draw it and just I will read out with you again. देखो, CSF is dark on T1, white on T2. Dark can also be called as hypo-intense or low signal. White can also be called as hyper-intense or high signal. Fat is white on both T1 and T2 weighted images. Cortical bone, calcium are dark on both T1 and T2 weighted image. Air is dark. Fibrous tissue, tendon, ligament, hemosiderin, flowing blood, dark on both T1 and T2 weighted image. Okay. Jevesh, meniscus, beta, meniscus that you have in your knee. Okay, we'll talk about it gradually. I will show you how it looks like. And this, if flowing blood is dark on both T1 and T2 weighted images, it is, we use a term flow void. We use a term flow void. Okay, so for flowing blood we use a term flow void. Clear everybody? Okay, so some bachas are saying, what about white matter, what about hemorrhage? I will tell you everything, but we will go step by step. Clear? Okay, now some bachas are saying how to differentiate between the images. Now is the time that we switch over to an image. In some of the image book, this image might not be there, so you can maybe take a snapshot, then just look at it and okay, let me just smile. Okay, take a snapshot and then we do it. Now, the key word in the exam is to see it practically. Nowadays, what is happening in the exam is they will say, look at this image and identify what you are looking at. Okay, anybody tell me the body part? Tell me the body part. This is brain. Very good, very intelligent. What section of brain is this? What section of brain? This is a transverse section of the brain, transverse section. But in radiology, instead of saying transverse, we will say axial section. This is a axial section of the brain. So abhi yaad kar lo. Instead of saying transverse, what will you say? Please say it out loud so that people sitting around you know that you are sitting in a class. Instead of saying transverse, you will say axial. You will say axial section. Okay. Now I will zoom the image. I will remove myself so that you have a clearer view, and I will mark the structure and ask you. I want you to see this closely. Can you see this dark area that I am labeling as bone? And this white thing that you see here is your fat in your scalp. Are you clear? Should I repeat? You can see. I'm just coming back on the screen now. The bone is dark, the fat is white. Can you see it here? The scalp fat is appearing white, the bone is appearing dark. Okay, this page is number 12 in some books. It is missing, so don't worry. Just take a snapshot, Ashwin and Angel and Sakshi. So now tell me, so bone is dark, fat is white. That means you are looking at a MRI image, because on a CT, bone should be white. You remember we saw this already? Now, second question. What is the color of CSF in this image? What is the color of CSF in this image? Anybody? CSF will be in the ventricles. Are you able to see here? Here lateral ventricle hai na? CSF is in the ventricles. Anybody now take a picture and tell me what is the color of CSF? Tell me. What is the color of CSF? Dark. CSF is dark. Very good, Saumadeep and Jaisal and everybody who's getting it right. Now tell me, beta. Now is the time to put your thinking hats on, and I'm sure you are aware of the fact that brain cortex is made up of gray matter, where you have the cell bodies of the neurons, and below the cortex you have the white matter, where you have the axons and the interconnections. Okay, I want all of you to look at the screen. मैंने zoom कर दिया, एक बार screen पे देखेंगे, and tell me what is appearing more white. What is appearing more white? Gray matter or white matter? What is appearing more white? So what is appearing more white? In this image, white matter is appearing more white as compared to gray matter. Okay. Now there is a reason behind it. The reason is, you remember in the gray matter, you have the neuron cell body. In the white matter you have the axons. And do you remember from your college days that the axons are covered with myelin? Axons are covered with myelin. And you remember from your biochemistry days that myelin has some inherent lipid. You might have read about sphingomyelin and stuff in the biochemistry class. So because of the lipid content of the myelin, and we know that the lipid in myelin, and we know on MRI T1 weighted images, the fat will cause the appearance to become more white. Because of the myelin lipid content, the white matter appears white on a T1 weighted image. These are the properties of T1 weighted image. I am repeating for the children who could not follow. Listen to me again, beta. And this is very important asked question. Okay. They will ask you, identify the image shown. How will you identify? पहले देखो CTA के MRI है. पहला तो क्वेश्चन है CTA के MRI है. Look at the bone. If the bone is dark and the scalp fat is white, this must be MRI. Then you see it is brain. Then this is a axial section. Then look at the CSF, dark. Look at the relationship between gray matter and white matter. White matter is more white, pointing towards a T1 weighted image. Okay. Now Ananya is saying, sir, how do we differentiate between T1 and T2? Ananya, don't run. Let me come to it. You know, I already know that this is what you will ask. So let's see the next image. Now Ananya will tell us. Look at this MRI brain. You can see this is MRI because the bone is appearing dark. the fat is appearing white. Okay. What is the color of CSF? Everybody put the chat box on fire and tell me what is the color of CSF in this image. इस इमेज में CSF किस कलर का है? Please tell me. Look at the ventricle. CSF कैसा है? Anybody? CSF appears white. CSF is white. Very good. Now I want you to look at gray matter, white matter differentiation. Now all of you now look at it. Please, please, please. I will remove myself so that you can look at the image alone in full zoom. Now please see, bacha. Are you all able to see that the white matter is appearing darker than the gray matter? White matter in this particular image is darker than the gray matter. Are you able to understand this? White matter is darker than the gray matter. So we will say white matter is appearing darker or hypointense than the gray matter. Why? Now here the reason is that although myelin has fat, what happens is whenever, listen to me everybody, whenever any tissue gets myelinated, it causes reduction in the water content in that area. Okay, so whenever there is myelination, the water gets resolved from that area. So water on T2 weighted image is white. If you remove water, it becomes dark. So white matter is darker on a T2 weighted image because of the reduced water content in the myelinated tissue. Okay, clear? And I think in some of the workbooks this page was not printed, so you can take a picture, and if you have not taken a picture, you can take it now. Okay, Remy? Now tell me everybody, are you able to understand now? बच्चे समझ पा रहे हैं? दोबारा से बताओ. Many times they will ask you this question. Okay, what is the appearance of gray matter, white matter on MRI? I am repeating, everybody listen to me. On T1 weighted image, white matter will appear more white than the gray matter. On a T2 weighted image, white matter will appear darker than the gray matter. Okay, Soumyadeep, are you clear? Are you clear, beta? So T1 weighted, T2 weighted. Now why do we need two images? Why do we need two images? Let me explain to you. Suppose I write down here T1 weighted MRI image, T2 weighted MRI image. Suppose I write, okay, suppose I write T1 weighted, T2 weighted image, okay, and I say what is the appearance of CSF? CSF is dark on T1, white on T2 weighted image. Okay, okay, okay. Now see, Rishabh, Abhishek, I know you are asking a question कि sir वहाँ पे ऐसा क्यों नहीं हो रहा? तो देखना है, देखो, try to understand. Different tissues are known to contribute to different levels at different images. What I am telling you is what is the main reason why white matter is more white than the gray matter on T1 weighted image. It is the lipid which is primarily contributing to this change. And why white matter is darker than the gray matter on T2 weighted image? Because it is the lack of water in the myelinated tissue which is contributing to this change. Okay, there could be multiple reasons, but this is the predominant reason causing this appearance. This is what you need to know in a crisp, concise one line. Nothing more you need to know. Now tell me, CSF on MRI is dark on T1, white on T2. My question to you is, what about any pathology? Suppose you have any disease, any inflammation, tumor. By now you know, if there is any inflammation, you will have edema. So edema will have, that means there will be increase in the tissue water. So edema or pathology will also be dark on T1, white on T2 weighted image. Okay, are we able to understand this? Are you able to follow my point? Okay, now tell me, everybody understand and see that T1 weighted image is good for depicting normal anatomy, but if I have to see a pathology, a disease, T2 weighted images are considered better. Everybody follow? Because it is easier for our eye to appreciate white. It is easy for our eyes to look at the white tissue, white area. So pathology is usually white on T2 weighted image and better seen on T2 weighted image, while normal anatomy is better seen on T1 weighted image. Clear? Everybody follows? Sneha, are you clear now बेटा? देखो दोबारा से सुनो कि दो MRI इमेज हैं, T1 weighted और T2 weighted. Out of them, normal anatomy is depicted best on T1 weighted image. Disease is best picked up on T2 weighted image. Okay. Now, I'm just showing the images again so that you can understand now. See this. This is a T1 weighted image. This is looking just like how the normal anatomy of the brain would have looked like. So it is more near to the normal anatomical depiction, T1 weighted image. T2 weighted image is the image where the water becomes more white and edema is also more white. So this image is done to pick up pathologies. This is able to pick up disease better. Okay, now tell me, anybody can answer my question now. I will give you a trick question now. Everybody, very difficult question. Very difficult question. Let's see how many of you can answer this question. I want you to look at this MRI. This is your bone. This is your fat. Okay. You can see the bone and the fat. I am removing myself. I want all of you to tell me what is the color of CSF in this image. I want all of you to tell me what is the color of CSF in this image. CSF कैसा है बेटा बताओ? CSF appears dark. CSF in this image is dark. But what about gray and white matter beta? So let us label it. This is your gray matter, the brain cortex. This is your white matter. Gray matter, white matter. Okay. Now anybody tell me, what is the appearance of white matter and gray matter in this patient? The white matter appears darker. In this image, the white matter is darker. Okay. Everybody gets it? Now my question to you is this. Now so far we have understood that if the white matter is darker than the gray matter, this should be a T2 weighted image. But in a T2 weighted image, CSS should be white. So that means in this image, it is primarily a T2 weighted image in which the CSF signal has been suppressed. In which the CSF signal has been suppressed. This image technology is called as FLAIR. This image technology is called as FLAIR. What is FLAIR? Fluid attenuated inversion recovery sequence. So I'm again repeating for the children who could not follow. FLAIR is nothing but a T2 weighted image in which the CSF signal has been suppressed. Fluid signal has been suppressed. What is FLAIR? Fluid attenuated inversion recovery sequence. Fluid attenuated inversion recovery sequence. Now, I am repeating now. Sangram. But before I repeat, try to understand the reasoning, then I will come back. Okay, beta? I will come back. Please see. Suppose you have a MRI technique called as FLAIR, which is using inversion recovery technique to suppress the CSF signal. So CSF will become dark. But it is inherently a T2 weighted image. So the edema will remain white. So are you able to now understand? ऋषभ, अब समझ पा रहे हैं कि फ्लेयर का फायदा क्या है कि ये सिर्फ CSF के सिग्नल को सप्रेस कर रहा है, जो एडिमा है टिश्यू के अंदर, बाउंड एडिमा है, उसको सप्रेस नहीं कर पाता. So now I am again repeating in English that flare has the advantage that it is actually a T2 weighted image, but it makes it easy to see the edema because the CSF has been suppressed. It is only suppressing the signal coming from CSF in a T2 weighted image. Interesting? Interesting? Okay. Now Shimran is saying, sir, if there is a disease, then what will happen? We will reach there. पहुंचेंगे वहां पे, पहले दूसरे स्टेशन आएंगे फिर पहुंचेंगे. So just like I taught you in CT, first we need to understand the normal. You cannot see the abnormal if we don't know the normal basic things. And that is how I have believed, this is how the exam bodies believe, that let us first check the basics. ठीक है, अभी सब छोड़ दो, अब सब छोड़ दो, अभी देखो मेरे साथ. Okay, CSF is dark, white matter is more white, T1 weighted image. Second part, CSF is white, but the white matter appears darker than the gray matter, T2 weighted image. CSF is dark, but the white matter appears darker than the gray matter. This is a flare image. They can ask you to identify in the exam. Okay. So in the real exam, they give a image and say identify the MRI image. T1, T2, flare. Okay. What are three MRI sequences that we use in brain commonly? T1 weighted image, T2 weighted image, flare. Okay. Okay. Everybody clear? Okay, Vaibhav, I hope now it is clear after I have repeated it all. Now, okay. Now I will make another statement, then I will explain to you. MRI is a true multiplanar imaging. That means because in MRI we are using radio frequency pulses, we can obtain images in any plane. We can obtain images in any plane like this. So can you now tell me what plane is this? This is a sagittal plane. This is a sagittal plane. So MRI can take images in any plane. So if they ask you what is the advantage of MRI? MRI is a true multiplanar investigation. Now, before we go on, let me answer a few queries that some bachas were asking initially. Okay. Now let us see some conceptual questions. We will apply them. Okay. Anybody will try to answer on the chat box. You can try and tell me. Okay. Calcification is best seen on CT, MRI. Tell me. Anybody can answer this question now. What is the answer? Okay. Calcification is best seen on CT ke MRI. Anybody wants to answer this question? Calcification is best seen on. Now remember, calcium on CT was white. Calcium on MRI is dark on both T1 and T2 weighted image. And what is easy for our eye to see? It is easy to pick up white. So that is why the answer to this question is CT scan. Clear? This has been asked as in FMG screening exam in the past, NEET PG in the past. But it is simple. C for calcium, C for CT. Calcification is best seen on CT scan. Okay. Now I will give you tough question, beta. Tough question. Okay, I am giving you a tough question to solve. ENT question, beta. ENT question, tough question. Suppose you have a glomus tumor at the area of jugular foramina. You have a glomus tumor. In the ENT, you have glomus tumor. This glomus tumor is very vascular. It's a very vascular tumor. So if you do MRI of this vascular tumor, this tumor will have a lot of blood vessels. This tumor will have a lot of blood vessels. And in the blood vessels, you will have flowing blood. Okay. I'm repeating, in a glomus tumor, you will have a lot of blood vessels which will have blood flowing in them. It's a very vascular tumor. Everybody listen to me. Silence, listen to me. Suppose I take a cross section of a glomus tumor. Cut kar raha hu. Okay, if I'm taking a cross section. The vessels will look like dot, dot, dot. You know, vessels are like this. If you cut them, they look like dot, dot, dot. Now, these blood vessels on MRI will appear dark. Why? This is called as flow void. Remember I told you, a flowing blood, if the blood is flowing, it should appear dark on MRI, it is flow void. So if you see a glomus tumor, the tumor will be white because it is a pathology, but it will have a lot of black dots inside because of blood vessels. Okay. And if you remember, the European people, before they came to India, before they were exposed to the spices of India, they only knew two things: salt and pepper. So this is called as salt and pepper appearance on MRI. Are you now understanding the logic behind, the why behind it? See, in ENT you were trying to do, glomus tumor has salt and pepper appearance, glomus tumor has salt and pepper appearance. I am telling you why it is there. Because it is a vascular tumor with lot of blood vessels with blood flowing in it. And if you take a cross section, they will look like black dots, because flowing blood shows flow void. Flowing blood on MRI appears dark. Imrose, now are you able to understand my question? Salt and pepper appearance on MRI is a sign of glomus tumor. So I gave you two whys. Calcium is best seen on CT, salt and pepper appearance on MRI. I will give you one more why. Now this is very difficult but very interesting. Listen to me. This is one question many people had asked me on Instagram after my previous class. I told them I will answer in the next class. Now listen to me, everybody. Suppose you have a brain hemorrhage. Suppose somebody has a brain hemorrhage. Okay. What will you see on MRI? What will you see in a patient with brain hemorrhage on MRI depends on the stage of the disease. If it is a acute hemorrhage, subacute hemorrhage, chronic hemorrhage. Okay. Now listen to me. Acute hemorrhage less than 48 hours duration. Subacute hemorrhage is divided into early subacute hemorrhage, late subacute hemorrhage. Early is 3 to 7 days. Late is 7 to 14 days. Chronic is more than 14 days. Chronic is more than 14 days. Okay, everybody listen to me. Now what is happening on MRI is, what is happening in MRI? In MRI, in the blood, the products keep degrading. I want all of you to listen to me. I'm just revising a little bit of biochemistry, then we reach to radiology. In the acute stage, everybody write it down. In the acute stage, the hematoma, the blood clot will have deoxyhemoglobin. In the acute stage, there will be deoxyhemoglobin in the blood clot. After 48 hours, it gets degraded into methemoglobin. It gets degraded into methemoglobin. After 7 days, the RBC membranes in the blood clot, they will lyse. The membrane will get destroyed in the blood clot, and the methemoglobin becomes extracellular methemoglobin. After 14 days, it gets further degraded into hemosiderin. It gets further degraded into hemosiderin. So, why the appearance of brain hemorrhage changes with stage on MRI? Because in the blood clot, the hemoglobin degradation product is different. In the first 48 hours, it is deoxyhemoglobin. In 3 to 7 days, it is methemoglobin. 7 to 14 days it is extracellular methemoglobin because the RBC membranes will lyse, and then it becomes hemosiderin. Okay, I will answer a question, but it is tricky and I want you to listen to me very intentfully. Okay, I want you all to listen to me. Beta, ध्यान से देखो. Deoxyhemoglobin is diamagnetic. Methemoglobin is paramagnetic in nature. Hemosiderin has a super paramagnetic property. Okay. Now Joel is saying, sir, एक्स्ट्रा सेलुलर का क्या मतलब? एक्स्ट्रा सेल के बाहर आ गया. देखो अभी शुरू में हीमोग्लोबिन आरबीसी के अंदर. जोएल लुइस, हीमोग्लोबिन वाज इनसाइड द आरबीसीज. आफ्टर अ वीक टाइम इन द ब्लड क्लॉट, दिस इज अ हेमरेज, सो ब्लड हैज कम आउट ऑफ अ ब्लड वेसल, इट इज क्लॉटेड. सो इन दैट ब्लड क्लॉट इन द ब्रेन, द आरबीसी membranes have lysed, so it becomes extracellular methemoglobin. Okay, now everybody listen to me beta, everybody listen to me. Diamagnetic paramagnetic matlab, it means it depends on the number of unpaired electrons in the outermost shell. How many unpaired electrons are there in the outermost shell? Acute hemorrhage, you have deoxyhemoglobin which is diamagnetic. That means it does not have unpaired electrons, so we might not be able to pick it up. That is why for the first 48 hours, NCCT is the investigation of choice. Should I repeat this? Very important. A lot of people asked me, sir, brain hemorrhage mein, should we do CT or MRI? The answer is CT. In the first 48 hours, MRI can miss brain hemorrhage because deoxyhemoglobin is diamagnetic, it does not have unpaired electrons. So NCCT is the investigation of choice for first 48 hours. Clear? Now, second question. Okay, second question. Paramagnetic मतलब there is unpaired electrons. Ferromagnetic मतलब होता है जो iron वाला में और ज़्यादा there are unpaired electrons. Now please see and understand. Now what happens is methemoglobin, because of paramagnetic behavior, appears bright on T1 weighted image, dark on T2 weighted image. Bright on T1 weighted image, dark on T2 weighted image. But when it becomes spread out, when the RBC membranes lyses, when the extracellular component of methemoglobin predominates, it becomes more spread out, magnetic property changes, and it becomes bright on both T1 and T2 weighted image. So subacute hematoma in the early stage is bright on T1, dark on T2. In the late stage, it is bright on both T1 and T2 weighted image. Chronic hemorrhage has hemosiderin, which is super paramagnetic. It is dark on both T1 and T2 weighted images, and it is better picked up on a special kind of MRI, which is called as susceptibility weighted imaging. Okay, I'm again repeating, listen to me. Please see and answer this very, very tough PG level question. Sometimes even MD students will struggle on the basics because basics are very difficult. Hi-fi things are, not required for anybody. Even if you go to MD exam, they will ask you what I am telling you, because everybody knows that basics are the key. Everybody listen to me. बच्चे सुनो मेरे साथ. Acute hemorrhage less than 48 hours in brain usually is better picked up on CT as compared to MRI because deoxyhemoglobin has no unpaired electrons. It is diamagnetic. Subacute stage, early will be bright on T2, late subacute will be bright on both T1 and T2 weighted images because of the paramagnetic behavior. Chronic hemorrhage after 14 days will have predominance of hemosiderin, which is a super paramagnetic substance, dark on both T1 and T2 weighted image, better on a special kind of MRI called as SWI. Okay. Don't worry, I will show it to you again. I will explain it to you again. But I am just trying to remove myself so that we have our table. Abhi kya, are you able to understand that why I was telling you whenever you have hemorrhage, stroke, please do CT to look for hemorrhage. MRI might miss the hemorrhage because I have given you a why. Clear, bache? Okay. So Devesh Pandya is saying, what is the role of unpaired electron? Devesh, beta, Devesh Pandya. Devesh, do you remember from school? Acha, Devesh, tell me, why is iron magnetic and some other metal is not magnetic? The magnetism is a property dependent on number of unpaired electrons in the outermost shell of the molecule. Outer shell में कितने unpaired electron है वो determine करेगा magnetic behavior. So diamagnetic means there are no unpaired electrons. Paramagnetic means there are unpaired electrons, and that is why their appearances are different. Clear? Everybody? Now, some people are saying, can you repeat SWI? Don't worry, I will repeat it with the image that chronic hemorrhage has hemosiderin, which is dark on both T1 and T2 weighted images. So we do a special MRI sequence called as SWI to confirm the presence of hemosiderin. Okay? Clear? Are you clear? So that means, like I think Mehak and Rishabh are asking, let me explain. Acute hemorrhage CT is better, but for subacute and chronic, MRI is better. So as a doctor, you should be aware of it that when you are doing, if a patient has brain hemorrhage and you think the duration is less than 48 hours, go for CT. More than 48 hours, go for MRI. Okay, Fenil Jagdish Patel, I will try to explain to you what you have asked. If you are okay, then otherwise leave it. Okay, not important. Please see. Suppose these are your RBCs. Okay, initially what will happen, Fenil, methemoglobin will be inside the RBCs. Then after 7 days, in 7 to 14 days, the RBC membrane will lyse. So the methemoglobin will become more spread out. So the magnetic behavior changes because of that reason. Okay, so some of you are still finding it difficult to understand the concept because the reasoning is not in the college, it is in the school. And because when you were reading in the school, this paramagnetic, ferromagnetic words were used by the teachers, but sometimes at that time you were not thinking that somebody will ask you later on in MBBS, so you have forgotten and you have erased. Don't worry. So somebody is saying, what is the principle of SWI? Don't worry, I will show it to you. Don't worry, we'll talk about it at length. Okay, so I just wanted to make sure that you understand the why behind things and you follow that. What I'm trying to tell you is clinical. Okay, now let's look at the sagittal image that we had started to look at. I will remove myself and put some numbers on the image. I am removing myself, putting some numbers at the image. Okay. Identify the area marked as number 1. Area marked as number 1 in the image is nothing but your cingulate gyrus. Area marked as number 1 is cingulate gyrus. Okay. Number 2. Anybody can identify the area marked as number 2 in the image. Number 2 batana aapne beta. What is number 2? Number 2 is your corpus callosum. Okay. Number 2 is your corpus callosum. Very good, beta. Very good. I can see so smart. You know, when I look at the chat box, I am like, under complex that you are such a good batch. You know, such a good batch. You know, I'm so proud of you. I've never seen so smart children in my life. Now tell me, anybody can identify what is this structure that I have marked with a green color? I have marked with a green color and putting a number 3 there. Number 3 is, this is your fornix. Number 3 is fornix. Clear, everybody? Number 3 is fornix. I want you now to answer what is number 4. What is the structure marked as number 4? Number 4 is thalamus. Number 4 is thalamus. And number 5 just below the thalamus. Number 5 just below the thalamus is hypothalamus. Number 5 just below the thalamus is your hypothalamus. Number 6, 7, 8. Okay. Can you see the brainstem? Are you able to see the brainstem marked as 6, 7, 8? Okay. 6 is your midbrain. 6 is your midbrain. 7 is your pons. 8 is your medulla. Okay. Very important. You cannot do these wrong in the exam. Otherwise it will be tragedy if you do basic things wrong. Again, you will see, I will take you to the top concepts, but not without telling you the basic anatomy, because otherwise everything will become haywire. Midbrain, pons, medulla. Look at the structure marked as number 9. So this is a midline sagittal section because we are going through the corpus callosum. Number 9 is the part of the cerebellum in the midline which is called as the vermis. Number 9 is vermis. Cerebellum or cerebellar vermis. Very good, Anamika. I think you got it right. Now I want you to see, bacha. I want you to see number 10. Can you see there is a CSF space between the pons and the cerebellum? CSF space between the pons and the cerebellum labeled as number 10. This is the cavity of the hindbrain called as the fourth ventricle. This is your fourth ventricle. Also make a note of number 11. Number 11 is the lowermost part of the cerebellum. So on the both sides, cerebellar hemispheres are like this and they have something going towards the midline. This is called as the tonsil. So number 11 is your cerebellar tonsil. Number 11 is your cerebellar tonsil. Okay. Now what we will do is, we will now go deeper into the anatomy. Once you are clear on this, that if especially AIMS people, they like sagittal anatomy more than the axial anatomy. So we have labeled the usual culprits in the exam. Sometimes they asked fornix, sometimes they might ask you midbrain, sometimes they might ask you pons, medulla. After my class, I am sure you should be able to do it. Okay, I will now make it slightly more tough for you. Okay, I will make it tougher for you. I am zooming it. And I want you to see this area, this particular area that I am trying to make, a cigar-like area. Okay, just behind the thalamus, you have a part called as epithalamus. Epithalamus, which contributes to this structure that I am drawing here, which is called as the pineal gland. This is called as the pineal gland. How will you locate the pineal? I am zooming out, zooming in. Ek baar dekho. This is your thalamus, sensory relay organ. Behind it, posteriorly, you will see the pineal. Clear? Okay. Now I will make a clinical vignette based on the anatomy that we have discussed. And then we will go one by one and see more tough questions. I am going to give you a question. A 12-year-old boy has upward gaze palsy. His MRI shows a mass in the posterior aspect of third ventricle. MRI shows a tumor in the posterior aspect of third ventricle. His CSF shows elevated beta HCG level. Okay. What are we dealing with? Okay, Surya and everybody. So I will show you the pineal again, but first see the question. Abhi, it looks like a pediatric question. Hi, because 12-year-old boy, pediatrics. Upward gaze palsy must be ophtha, pediatric ophtha. MRI, radiology question. Beta HCG, pathology question. What is going on? So such a question is called as clinical vignette, or we will say integrated MCQ. Okay, everybody now Sarthak and everybody please see, I am again showing you pineal again beta, hai na? Abhi, if you have seen it, now see this here. This is the pineal gland beta, this is the pineal gland. Pineal is located in the posterior part of the diencephalon. So this is the pineal which is colored as yellow. Suppose you have a pineal tumor. So if you have a pineal tumor, it will be like this. Number 6 was the midbrain. In the midbrain, you can see the aqueduct passing through it, and behind it you have the colliculi. So this is your superior colliculus. This is your inferior colliculus. So bacha, please tell me, if there is a pineal tumor, what will it compress? It will compress the dorsal part of the midbrain. Pineal tumor will compress the dorsal part of the midbrain. It will compress the superior colliculi, which is responsible for the vertical gaze, and the patient will develop upward gaze palsy. This is called as, in ophthalmology, it is called as Perinaud syndrome, or we can say dorsal midbrain syndrome. Okay. So if there is a pineal tumor, it will compress. If there is a pineal tumor, it will compress the dorsal part of the midbrain, which is called as the Perinaud syndrome. The patient will have upward gaze palsy. Okay. On MRI, the tumor will be seen posterior to the third ventricle because pineal is located to the posterior part of the diencephalon. But then why is the beta HCG level raised in the CSF? Beta HCG is a marker of germ cell tumor. Pineal has germ cells, so it could be a germ cell tumor of the pineal gland called as germinoma. What is the answer to the question? Germinoma of the pineal gland. Are you able to understand my question? Are you able to understand? Now, again, I see one bacha is saying, sir, how do we know that this is a T1 weighted or T2 weighted image? But again, you will have to look at the CSF. CSF is the first clue for you, beta. CSF is the first clue for you. I will try to zoom the image for you. CSF is the first clue for you. Can you see the fourth ventricle? The CSF is black. This is the T1 weighted image. Everybody follows? So are you able to understand how a clinical vignette is structured? Okay. Pineal tumor, Anmol's core, pineal tumor will compress the dorsal part of the midbrain. देखो यहाँ पे pineal है, एक बार दोबारा देख ले बेटा, है ना? एक बार देख लेते हैं, सुन लेते हैं, it will help us. This is your pineal gland, and this is where you have the colliculi, superior colliculi, inferior colliculi, the dorsal midbrain. So if there is a pineal tumor, it is going to compress it, and that is why in ophthalmology you have talked about Perinaud syndrome in pineal region tumors. Are you able to follow? Okay. So some bacha is saying, Nidhi is saying, sir, posterior commissure kahan hai? Very good. I will show it to you. So Nidhi, please see beta. This is where you have the posterior commissure. Just above the superior colliculi, you have the posterior commissure, and pineal ke just upar, this is the area of habenular commissure. The dotted line that I have drawn is the habenular commissure. Habenula. Okay. And the red dot is your posterior commissure. Okay. Now, why the question is, okay, the question was why beta HCG is raised? Because beta HCG is a tumor marker of germ cell tumors. Pineal is a area in the brain where you can have germ cell tumors. Many times you forget germ cell tumors, you think only in gonads, but germ cell tumor can occur anywhere in the midline of the body. Even in the mediastinum, you can have germ cell tumors. You might have heard of that Yuvraj Singh had a mediastinal germ cell tumor. So sometimes you forget that beta HCG raised in CSF could be a marker of germ cell tumor. In brain it occurs in pineal, and that is how the entire question has been structured. This is a pineal germinoma. Okay. Now one bacha is saying, sir, aqueduct of Sylvius dikhao. I will show it to you, beta. Okay, I will show it to you. This is your aqueduct of Sylvius. Can you see the dotted line passing through the midbrain? You can see this is your aqueduct of Sylvius. दिखा कि नहीं, एक duct दिख रहा है ये वाला. Okay, aqueduct of Sylvius. Now the question is, let us now look at one more question, one more clinical question. I will identify a part for you, then I will ask you to give me the diagnosis. Okay. I will mark a structure for you. You have to tell me what is the structure. Now all of you beta, focus on the screen. This is your midbrain. Okay, this is your midbrain. Anterior to the midbrain, you have this body sitting here. Okay. Anterior to the midbrain, we have this body sitting here, which I have marked as a white with yellow arrow. This body that I marked here is your mammillary body. Name a condition in which mammillary body is involved and patient comes to you with acute confusional state of thalmoplegia and ataxia. So look at the triad, three feature triad. Okay. Name a condition which is known to involve the mammillary body. Patient comes to you with acute confusional state of thalmoplegia, ataxia. So answer to this integrated question will be Wernicke's encephalopathy. Wernicke's encephalopathy. Due to deficiency of what? Due to deficiency of what? Anybody can answer. Due to deficiency of thiamine. Vitamin B1. Clear? So acute confusional state of thalmoplegia, ataxia, involvement of mammillary body. Think about Wernicke's encephalopathy. Think about Wernicke's encephalopathy. Clear? Okay, beta. Very good. So I will give you one more integrated question just like this. Okay. So you have to see that they will try to put some clinical symptoms, some radiological images. Don't get confused. Just apply common sense and come back and give your interview to me. Okay. Now see, let's see if you can answer. I will make it more tough for you, beta. Now please see, anterior to the mammillary body, if you look closely, this is your infundibulum, pituitary stalk, and this is your optic chiasma. I am labeling it, beta. Optic chiasma, infundibulum. Okay. अब बच्चे एक बार देखो, I have tried to zoom it. I am removing myself so that it is clear to you. एक बार देखना. Please see between the mammillary body. एक बार देखना mammillary body और optic chiasma के बीच में देखो. This is your hypothalamus. This area. Okay. Try and see an area which is the lower part of the hypothalamus, just between the mammillary body on one side and optic chiasma on the other side. This particular area is called as, anybody? This particular area is called as tubercinarium. This particular area is called as tubercinarium. Very good, Ankita. This is called as tubercinarium. Okay. Now anybody can answer this question, beta. इसको बताना है आपने, है ना? Tubercinarium is a part of which structure? It is a part of hypothalamus. It is a part of hypothalamus. This is the area where you can see a tumor arising in patients with, I'm going to just tell you, this is the location of hypothalamic hamartoma, and the patients with hypothalamic hamartoma present with two typical features. Either the question will tell you precocious puberty, or the patient will be having gelastic seizures. Okay. Now, anybody can tell me, Simran, I'm again repeating for you, between the mammillary body and the optic chiasma, the flat area of hypothalamus that is marked as yellow is called as tuber cinereum. Anybody tell me, beta, tuber cinereum is the location of hypothalamic hamartoma. The patient will present to you with precocious puberty or gelastic seizures. What are gelastic seizures? Bouts of laughter. Bouts of laughter. Gelastic seizures are nothing but seizures which are uncontrolled bouts of non-joyful laughter. Clear? Okay. One more question. So these are the locations. Now I am again explaining to you. This is your midbrain. Anterior to the midbrain you have mammillary body. Anterior to the mammillary body you have tuber cinereum. Then you have the infundibulum. Then you have the optic chiasma. Now I want you to look at the pituitary also with me. I want you to look at the pituitary also with me. I'm again repeating, Abhishek, कि hypothalamic hamartoma कहां से arise करेंगे? They arise from the tuber cinereum. Tuber cinereum. And what will be the symptom? Precocious puberty or a typical seizure of laughters called as gelastic seizures. Okay. Now let me ask you a question now. This is the toughest question now in the discussion, and then we will move forward. Just one more tough question, then we will move forward. Just one or two tough questions here. I want you to look at the pituitary. I want you to look at the pituitary without me. It has an anterior part and a posterior part. The yellow arrow is marking the anterior part of the pituitary. The blue arrow is at the posterior part of the pituitary. Are you able to appreciate that the posterior part is appearing more white? This is called as the pituitary bright spot. Anybody? Pituitary bright spot क्या होता है? It is nothing but your posterior pituitary. Because of presence of ADH, which is also called as vasopressin. Now, this ADH or vasopressin has paramagnetic behavior. It is paramagnetic molecule. So what happens is, it changes the magnetic property, and posterior pituitary in a normal person will have bright appearance. So that is called as pituitary bright spot. So what is pituitary bright spot? It is nothing but your posterior pituitary. So that makes me ask you a question. If your pituitary bright spot is absent, if in a MCQ they say there is absence of pituitary bright spot, that means ADH is not there. What could be the condition? ADH नहीं है, क्या हो सकता है? Then we think of central diabetes insipidus. So there is a reasoning for everything. Only thing is we need to apply our mind and spend some time together. Time to लगाना पड़ेगा. If we spend time together, we get the why behind it. Okay. You remember endocrine, they were telling the pituitary bright spot absent, central diabetes insipidus. I've given you the why behind it. Pituitary bright spot is nothing but posterior pituitary. Okay. Which is bright due to ADH, which is paramagnetic. Are you clear, Rishabh? Okay. Pituitary bright spot is nothing but your posterior pituitary, which is bright because of presence of ADH or vasopressin, which is paramagnetic in behavior. Okay. Now I also wanted to show you a tough question, one more tough question, and then we can move forward. The difficult question is, an ENT surgeon An ENT surgeon discovered a nasopharyngeal mass in a patient which on biopsy revealed physalliferous cells. What is the likely tumor? Okay. Anybody please answer? Okay. Okay, I'm going very, very slow now. I'm going slow. Tell me. Anybody wants to tell me? A ENT surgeon discovers a nasopharyngeal tumor which on biopsy had physalliferous cells. Now, everybody follow me. Please see and listen to me. So, this is where you have your spine. This is your spine. And you remember that in embryology, earlier in the beginning part, this area has the notochord. Notochord is still here. Okay. Then the notochord regresses. I'm sure you might have read about this in your, embryology. But sometimes some tissue of notochord might be left behind in the clivus bone. This is your clivus bone. And suppose this notochord remnant undergoes a neoplastic change, you will develop a tumor. This tumor will go into this is nose. So what is this area? This is the nasopharynx. This tumor will go into the nasopharynx. And physalliferous cells are nothing but large cells that you see in notochord. So what is your answer? Chordoma. What is your answer? Chordoma. Everybody understands? So what is chordoma? Chordomas are nothing but notochord remnant tumors which can be seen as nasopharyngeal masses in ENT. Everybody follows? Okay, so let me repeat. So I'm again repeating for Aksa Nayab. Okay, dekho. What happens is sometimes we might get confused that what are they asking in radiology and ENT, and you might think that ye to sab khichdi pak gaya. Because human body, everything is interconnected. Now this bone that I am trying to show it to you, I will just zoom it. I will clean up the mess. Don't worry. I will clean up the mess and show it to you with the diagram once more. Don't worry. Please see. This is where you have your sphenoid sinus. This is your nose. This is your nasopharynx. Okay. Just behind the nasopharynx, Mathangi and other bacha who was asking, this is a bone called as clivus. Okay. Sometimes you might have a notochord remnant sitting in the clivus and it might turn into a neoplasm. It can, similar thing can also happen in your sacrococcygeal area also. If you have notochord remnant in the sacrum and coccyx, it can develop into a tumor called as chordoma. So if there is a tumor developing here, where will it go? It is in the skull base, but it will extend into the pharynx, nasopharynx. And who will see it? ENT surgeon. ENT surgeon. Okay. And who will answer it in the exam? Radiologist. Clear? So I hope now you understand. Okay. I hope now you understand that why radiology is such, fascinating, because it becomes multi-system immediately. Because skull base is close to the area of the ENT surgeon. So once you reach to that area, you are also, they can make an integrated question with the ENT surgeon. Okay. Now again I see some bachas are saying, sir, clivus being a bone, why it is bright, and I saw some bacha was saying cortical. Wait for some time, I will answer every question, because bone has two parts: cortex, bone marrow. Bone marrow will be white because of the fatty content. I will talk about it at length. Just give me 1 minute. So let me answer a question. Ek bacha keh raha, sir, fornix bana do. So this area is your fornix. On MRI, this is your fornix. And some bacha is saying, where is thalamus and hypothalamus? So this is your thalamus, this is your hypothalamus. Clear? Okay. So once you are clear, let us revise the ventricular system once more. This is what we have seen in different parts of the class. This is your lateral ventricle, anterior horn, posterior horn, inferior horn. This is your ventricle, aqueduct, fourth ventricle. Everybody clear? Are you able to remember this 3D diagram from your class, from your anatomy class? Okay. Now my question to you is this, beta. Okay, Aditi and everybody, just tell me this question. Okay, let me ask you a question. What could be this anatomical structure? Okay. Hello, can you hear me? Okay, so let's try to answer it again. Can you hear me, everybody? So this structure is below and behind the inferior horn of lateral ventricle. So if this is your inferior horn of lateral ventricle, just below and behind it you have your hippocampus. This is where the hippocampus is located. Okay. Now a very interesting concept is, if I take a coronal section of the brain, it will be like this. And if I take a oblique coronal section, it will be like this. Okay. Now sometimes what they do is they ask you a question. Hippocampus is best evaluated on a coronal section or a oblique coronal section. Anybody? Hippocampus is best seen on a coronal section or a oblique coronal section. Now ideally it should be coronal, but because hippocampus is located in a slanting manner, if I take a oblique coronal section, it is perpendicular to it. So by now you know, if you cut a structure perpendicularly, that is, you are able to cut it better. So hippocampus is best evaluated on a oblique coronal section. And why would you want to evaluate hippocampus? If you are suspecting Alzheimer's dementia, you want to look at the volume of hippocampus. Any other reason? If you are suspecting mesial temporal sclerosis in a patient with complex partial seizures. So I'm sure you might have read about temporal lobe epilepsy कि अगर complex partial seizure है तो we need to look at the hippocampus on MRI, that is called as mesial temporal sclerosis. Everybody follows? So in patients with Alzheimer's dementia suspected, or in patients with mesial temporal sclerosis, we do a oblique coronal section. I will explain to you with a image. And I think some bacha is having some local issue. Please see it locally. This is how a T2 weighted image, coronal image, will look like. Now Aditya is saying, what is CPS? CPS is complex partial seizure. Complex partial seizures or temporal lobe epilepsy. You can see here, this is your lateral ventricle. And you can see the temporal lobes hanging down. You can see the third ventricle here. Okay, all the anatomy that we've already seen, this is the coronal section through the brain. And we will not differentiate it. There is no need to differentiate. Just remember that the area that I have marked now, these are your hippocampi. Hippocampus. This is a oblique coronal section. And how to identify hippocampus on a coronal section? First identify the temporal lobe, go medial to it, and just below your inferior horn of lateral ventricle, just below the inferior horn of lateral ventricle, if this is the inferior horn, you have the hippocampus. Okay, Rishabh, I will scroll up. Give me just 1 second. So you can see the symmetry here. These are your hippocampus. So you can see the volume here. This will be reduced if this is a patient with temporal lobe epilepsy, or it might have atrophy in Alzheimer dementia patients. So always remember that you look at the coronal section, preferably oblique coronal section, look at the temporal lobes, go medial to it, and just below the inferior horn you can see the hippocampus. Compare it to the other side. Okay, Imrose, are you able to remember, Imrose? In the previous class I talked about के mesial temporal lobe में we will see the amygdala anteriorly, uncus medially, hippocampus posteriorly. Okay, every image that we have seen today has been a MRI. Every image that we have seen is a MRI Sangram. Please beta, you can see this is your bone and this is your scalp fat. Okay, every image that I have shown you today has been a MRI. Okay, Manish. Okay. Okay, so with your permission, just to remind you that hippocampus is nothing but looks like a seahorse in your gross anatomy. So this is what you might have seen in your anatomy class. Slightly different from what we have learned in the radiology. We have learned that the hippocampus is seen in the mesial part of the temporal lobe, below the inferior horn, slightly posterior to it. That is the location of hippocampus. Clear? Okay, now, so before we go further, I think we can just summarize. I'm just summarizing, listen to me. Whenever we do MRI brain in any patient, we obtain these images: T1 weighted axial, T2 weighted axial, flare axial. We obtain one sagittal image, one coronal image. Okay, in every patient we at least obtain these images. But if it is a child with epilepsy or a patient with old person with memory loss, we will add oblique coronal. Oblique coronal is not done routinely. It is done only when we are thinking of hippocampal pathology. Routine person, we will do sagittal image, coronal image, axial image, T1 weighted, T2 weighted, flare. Every patient we will do all these images. Okay, Shraddha Gupta, second image was a T1 weighted image. Absolutely correct, Shraddha. And Arshad, this was a T1 weighted image. The CSF is dark and the white matter is more white. Very good, brilliant. Okay, everybody understands? Okay, we will talk about diffusion weighted MRI also, don't worry, we will reach to that level. Now what we can do is, I think it's a good time that after this I will show you some more advances of MRI. What MRI can do other than what we have seen. This is routine brain MRI. Samruddhi, I just said ना कि हम oblique coronal तब करेंगे अगर if you are thinking of a problem in hippocampus, जैसे एक complex partial epilepsy का patient हो या Alzheimer's dementia suspected हो. Okay. Now one bacha is saying, sir, sagittal mein will we take T1 and T2? It depends on the institute. Some people take both T1 and T2. Some people obtain either one of the sagittal and coronal, one in T1, one in T2. Okay. Don't worry about SWI. I will show it to you again after the break. So what we have done so far is I have shown you, I will revise with you. Listen to me. I have shown you how to look at a MRI image, basic principles of MRI, T1 weighted image, T2 weighted image. Okay, we have also seen the flare image, we have seen sagittal anatomy, and why we need a coronal and a oblique coronal image. What is the difference between the two? Okay, now I want to tell you that MRI can do even more things than what we have seen so far. That is why I wanted you to take a breather. MRI is a very powerful investigation. It can do more things than what we have seen so far. It can even do spectroscopy. With MRI we can do spectroscopy. And what is it that we can see on spectroscopy? We can see the biochemical metabolites. So sometimes they might ask you in the exam, with which investigation can you see biochemical metabolites in the brain? In which investigation can we see biochemical metabolites in the brain? The answer is MR spectroscopy. I want you to see a few small chemicals in the brain. This is how the normal brain, any part of the brain, this is how the normal should be. This is choline, creatine, N-acetyl aspartate, lipid, mobile lipids. Now I will write down 3 lines in front of you. You need to write down those lines here. Choline is present in the cell membrane. Choline is present in the cell membrane of the tissue. Creatine is the energy storehouse of the brain tissue. Okay. Lipid is present, if a free lipid is present in necrosis in the brain. Okay. NAA is N-acetyl aspartate, which we will talk about in a brief file. NAA is N-acetyl aspartate. Now imagine now, everybody listen to me, okay? Suppose this is your brain and suppose you have a tumor sitting here. Suppose this is a tumor, okay? In a tumor you will have increased number of cells. Increased number of cells means increased number of cell membranes. So you will have a lot of cell membranes. So if you have a lot of cell membranes, what will happen to the choline? Choline in a tumor will be high. Tumors will be metabolically active, so they will deplete the energy storehouse. Creatine will be reduced. So suppose if they ask you, what happens in a patient with brain tumor on MR spectroscopy to choline and creatine? Choline will be high, creatine will be low. Okay, creatine is the energy storehouse in the brain tissue. It is the energy store. You might have read about this in brain. The energy is stored as creatine phosphate. So creatine will be depleted in tumors because they are metabolically active, while choline will be high because there are a lot of cells and lot of cell membranes. Are you able to understand? Should I repeat Ashu and Simran and Shekhar for you? So far I have told you that in brain we can see the biochemical metabolites using an investigation called as MR spectroscopy, in which choline is a marker of cell membranes, creatine is a marker of energy storehouse in the brain. In brain tumors, choline will be high, creatine will be low. Okay. And what about necrosis? What about necrosis? If there is necrosis in the brain, that area will have high levels of lipid. And can you name a disease in which you have necrosis? Tuberculoma. So this is a very popular question, multiple times asked. I will repeat it when I talk about the TB of the brain. But today I want you to know that if you do MR spectroscopy in a tubercular lesion of the brain, you will find a lipid peak. Normally the lipid is very less in the brain, free lipid. The lipid is only in the myelin, bound to myelin, not free. If you see mobile lipid, that means we are looking at a necrotic area. In India, it is typically a tubercular lesion. Are you clear? Everybody able to answer this? Okay. So I am again repeating that MR spectroscopy is an investigation in which we can see biochemical metabolites in the brain. Elevated choline levels is a marker of more cell membranes. It is a marker of brain tumors. While I have also talked about lipid is a marker of necrosis, so it is seen in tuberculomas. Lipid peak, tuberculomas. Okay. And finally, I said N-acetyl aspartate. So this is what we have done after the break. Only this part we have seen, nothing more than that. Okay, I'm again repeating that on MRI, using special technology called as spectroscopy, we can assess the biochemical metabolites. This is how a spectroscopic image of the brain will look like, and we will see different tissues, different metabolites will show different peaks. If choline is elevated, it means that the cell membranes are more in that area, which is a marker of brain tumors. Second is, I have also talked about lipid is seen in necrotic tissue in the brain, so it's a marker of tubercular lesions of the brain. It is a marker of tuberculomas. And thirdly, N-acetyl aspartate in brain is degraded by an enzyme called as aspartoacylase. N-acetyl aspartate is degraded by an enzyme called as aspartoacylase. If you have deficiency of aspartoacylase, it is called as Canavan's disease. It is called as Canavan's disease. Okay, so the graph that has been given to you is a normal MR spectroscopy of the brain tissue. If N-acetyl aspartate is elevated, what will you think? You will think that this patient has a Canavan's disease. Again, it is even given in your pathology book also that in patient with Canavan's disease, which is an inborn error of metabolism where the aspartoacylase is deficient, in brain tissue, in central nervous system, N-acetyl aspartate will accumulate. Okay, now some bachas are saying, is this the normal spectro? Yes, this is how the normal spectroscopy of the brain will look like. And what I mean by mobile lipid is that there is some lipid which is bound to myelin. That is not being seen here. Mobile lipid means that it is free lipid that is seen in the necrotic tissue. If it is a tubercular lesion, you will see a lipid will be more than what we see normally. Okay, so I'm again repeating. MR spectroscopy, only three things are important. Okay, this is how a normal MR spectroscopy looks like. If the choline is elevated, that means the cell membranes are more, that means you're looking at a brain tumor. If the lipid is elevated, that means you're looking at necrosis. Necrosis is a hallmark in a brain lesion, tuberculoma. If the N-acetyl aspartate is elevated, think of an inborn error of metabolism called as Canavan's disease. Clear? Okay. Now I'm zooming out for all the bachas, and I hope you are able to write. Okay, so I hope now you are able to get the basic concepts right. Now, clear? Okay. Second question. MRI can also look at the particle motion, or it can also look at the Brownian motion happening in the tissue. Okay. MRI can also assess the particle motion. Everybody clear? Okay. The MRI technique which can see the particle motion is called as diffusion weighted MRI, which is called as DWI. Okay, which is called as DWI. What is DWI? Diffusion weighted imaging. What is it sensitive to? It is sensitive to particle motion. Now I will tell you one line and I want everybody to listen to me very carefully. Very important question. Whenever there is ischemia in the brain, ischemia matlab reduced blood flow, ATP will be reduced. ATP will be reduced. If the ATP are reduced, what will happen? Sodium, potassium, ATPase will not be able to function. If the sodium, potassium, ATPase does not work, if the sodium, potassium, ATPase does not work, the cell will die and it will become swollen. Okay? And some bachas are saying how to look at neurocystic sarcosis. Abhi break lagayenge. I will tell you. Don't worry. We will reach there. We will reach there. We will do everything. Okay. Have patience. Be with me. We will cover it. Okay. So my question to you is, if there is ischemia, ATP will reduce, sodium, potassium, ATPase will stop functioning, the cell will die and it will become swollen, which is called as cytotoxic edema. Now, you cannot see this in a routine MRI. You cannot see this in a routine CT. But diffusion weighted MRI, listen to me, DWI is sensitive to particle motion. So if the sodium, potassium are not moving, DWI can detect the brain infarct earliest. At the stage of cytotoxic edema itself, it can detect the brain infarct earliest because it is sensitive to particle motion. As early as 3 to 30 minutes of onset, you can detect the infarct on diffusion weighted MRI. Okay, now listen to me. एक बार देखो everybody. So please see this area. Everybody focus on it. What is this? Hyper intense area. Bright area. So this is the area where the particle motion is not happening. Why it is not happening? Because this is a infarcted tissue. Rest all is normal. So infarct on a DWI is appearing hyper intense. On diffusion weighted MRI, wherever particle motion stops pathologically, that area is shown as bright. Okay, so the question is this, very often asked, which MRI sequence can detect the brain infarct earliest? The answer is diffusion weighted MRI. How early? 3 to 30 minutes of onset. Now immediately I see Harshvardhan asking a question and I can see a constant confusion in the bachas. If a patient has stroke, I want you to, maybe you can note it down also. If you have a suspected stroke, how will you do radiology? First thing you should always do is NCCT. What are you looking for? What is the advantage of NCCT? NCCT can pick up hemorrhage better than MRI, or if there is a large infarct, we can see it. If there is no hemorrhage, no large infarct, you will do a CT angiogram to look for any large vessel or large proximal vessel being occluded, which can be, if that thrombus can be, if it is there, can we take it out mechanically? So first you do NCCT. If it is normal, if it is not showing hemorrhage, not showing large infarct, you will do a CT angiogram. Clear? If the CT angiogram has a proximal occlusion, then you will do a diffusion weighted MRI. Okay. If the diffusion weighted MRI says that the infarct volume is less than 70 ml, you will go for intra-arterial therapy. If it is more than 70 ml, then you will do a MR perfusion study to find if there is any penumbra or not. Okay. Even if you forget what I am saying, it is okay. Just remember the sequence. NCCT is the first thing to be done to look for hemorrhage. Hemorrhage in first 48 hours. Harshvardhan was also asking this question, that NCCT will pick up hemorrhage. That is, it is better than CT in first 48 hours. It is better than MRI in first 48 hours. So we will first do NCCT. If NCCT is normal, you will do a CT angio to look for any proximal large vessel occlusion. If that is there, then you do a diffusion weighted MRI to look for infarct core volume. And then we decide if we can go give intra-arterial thrombolytic therapy, or we need to do a perfusion study to find out penumbra. Okay? Everybody follows? Okay. Now, once you are clear, I am just repeating it for all the bachas. All you need to remember is these 3 lines. Okay, just 3 lines you need to remember. बाकी बाद में देखना. अभी पहले 3 याद कर लेते हैं, ठीक है? I am going to write it down बेटा for you. I am going to write it down for you. Don't panic, don't घबराओ नहीं बेटा. एक बार लिखेंगे, ठीक है? If they say investigation of choice for acute stroke, please mark NCCT, because the main goal of NCCT is to rule out hemorrhage. To rule out acute hemorrhage. If the CT is normal, if there is no hemorrhage, then go ahead and do a CT angiogram. Then go ahead and do a CT angiogram to look for any proximal large vessel occlusion. Okay? If the CT angiogram is abnormal, then we go and do a diffusion weighted MRI to look for the infarct core volume. We want to find out the volume of infarct. If it is small, that means it can evolve further. You will go for thrombolytic therapy. If it is a large infarct, then you do a MR perfusion study to look for penumbra. I can see some bachas are getting now panicky, sir, ye penumbra kya cheez hai? Penumbra is the area at risk. Area at risk matlab a part of the brain which is ischemic but not yet dead or not yet infarcted. मतलब वो हिस्सा ब्रेन का जहां इश्कीमिया तो है, but it is not yet dead, it is not irreversible damage, and if you give thrombolysis you can reverse it. I will explain it to you. Try to understand. I am explaining it to you, beta. Okay? Please see, if this is your brain, suppose this is your brain, and suppose this is one blood vessel supplying the brain. Suppose this blood vessel becomes narrow. Everybody listen to me, okay? No, nothing to write down, just understand. If the blood vessel is occluded, what will happen? This entire area will have ischemia, reduced blood flow. And because of ischemia, after a certain time, what will happen? Some part will start to die. Some part will start to die. So this dead tissue becomes infarct. Dead tissue becomes infarct. Now, I want all of you to understand. Look at this area which is ischemic but not yet dead. What is this? This is the area around the dead tissue, area at risk, called as the penumbra. When we give thrombolytic therapy, when you give alteplase, you are trying to save the area at risk, which is ischemic but not yet dead. To see that, we need to do the perfusion study. So that part you can still ignore, but at least this sequence you should know. NCCT followed by CT angio followed by diffusion MRI. This should be the sequence. Okay? Krish कह रहा penumbra को क्यों बचाना है? बेटा, try to understand. If you have in ischemia, एक बार समझते हैं. I will repeat in Hindi English both. देखो, अगर blood flow कम होगा तो brain का या heart का वो tissue मर जाएगा. मर गया तो हम उसे कुछ वापस नहीं कर सकते. But if it is ischemic, not yet dead, it is salvageable. You can prevent the damage from happening by giving thrombolytic therapy, recombinant tissue plasminogen activator that you might have studied in your pharma class. Clear? So that is the goal. That is the goal that we have. That is why I have shown you CT of brain hemorrhage, and I am also showing you MRI in a patient with infarct. This is diffusion weighted MRI. Immediately when I said diffusion, I can see one bacha is saying, sir, wo apna SWI bhi dikhao. I will show it to you. One bacha is saying, what is IA? IA is intra-arterial therapy. Intra-arterial therapy. Now see this area, this image. This image right from my workbook was asked in a AIMS exam. This is a image which is called as SWI. This is susceptibility weighted MRI image. Susceptibility weighted MRI is sensitive to magnetic field changes around venous blood flow, slow venous flow, and around hemosiderin. Okay, I want all of you to listen to me. Can you see this multiple brain blood vessels at the surface of the brain? And with SWI, it is so sensitive to the venous flow that you see a lot of blood vessels. And if there is any hemosiderin, if there is any brain hemorrhage, that is also shown as a dark dot. Okay, so it is able to show you hemosiderin. When will you see hemosiderin? If there is a chronic bleed. That means if there is a old bleed, old blood, it will be seen in SWI. SWI can find out if there is a old bleed. Now, why would you need to see old bleed? I will explain to you. Listen to me. I am going to give you a clinical question. Same question from my class was there in last year in INI CT exam. Let's see if you can answer this question or not. Question is this. Patient had a high speed motor vehicle accident. High speed motor vehicle accident. After that he has been comatose. You are suspecting that there is shearing injury in his neurons. There is shearing injuries in his neurons leading to these axons getting damaged here. There is gray matter is moving over the white matter because of the high speed motor vehicle accident. Shearing injury leading to a comatose state, poor prognosis. What is it that I am trying to describe? What is it I am trying to describe? This is called as diffuse axonal injury. This is called as diffuse axonal injury. Anybody try to understand? So what is diffuse axonal injury? This means that in patients with high speed motor vehicle accident, if you develop shearing injury to the axons, the patient can become persistently comatose, poor prognosis. In these patients, when we do the CT scan, initially it might be normal, or the CT scan might show petechial hemorrhages. Okay, CT scan might be normal, or you might see some petechial hemorrhages. But the importance is, investigation of choice, if this is suspected, should be MRI. On MRI, if I use SWI, I can see black dots of hemorrhage in the gray-white matter junction. Because we already know, if you have a brain hemorrhage, blood clot will be degraded to hemosiderin, which can be seen on SWI as very, very dark spots. In addition to gray-white matter junction, you can also see blood in the corpus callosum, or in your, anybody, also in your midbrain. They might say midbrain or brainstem. Okay? Are you able to understand this? So why do we need SWI? SWI is able to help us in diagnosing a comatose patient after head injury. Patient had head injury 2-3 weeks back, maybe 4 weeks back, month back. He's still comatose. But the CT is not showing anything. What should you do? You should do a MRI. What is the investigation of choice for suspected diffuse axonal injury? MRI. Which MRI sequence? SWI. Because it can show me hemosiderin. Where will you see hemosiderin? Gray white matter junction, corpus callosum, midbrain. CT scan done initially may be normal, or it might show petechial hemorrhages at the gray white matter junction. Clear? Yes, we cannot see it immediately, and sometimes you don't suspect it immediately also, because we suspect diffuse axonal injury if the patient is persistently comatose after a head injury. After head injury, if the patient is persistently comatose, you will do a MRI. Clear? Okay. Okay, everybody clear? And the finding will be, you will see hemosiderin. Okay, you will see hemosiderin, that means black spots in the gray white matter junction, corpus callosal or midbrain. Now Ashwin is saying, sir, why don't we see the axonal structure? Okay, Ashwin, I am asking you to patience. I will reach there. I will reach there, but I will reach there. Listen to me. Okay. So once you are clear with this much, I also want you to know that in patients with cerebral amyloid angiopathy, before I talk more about diffuse axonal injury, just remember, in patients with cerebral amyloid angiopathy, old people with cerebral amyloid angiopathy, there are two things. Either you will have small petechial hemorrhages, multiple small petechial hemorrhages, or you will have a large lobar hematoma. This large lobar hematoma you can see on a CT scan, but small petechial hemorrhages you might not see on a CT, so we need to do a SWI. Okay. Susceptibility weighted MRI is a special MRI sequence which is based on magnetic field changes caused by hemosiderin or by venous blood flow in that localized area. It is that if you have hemosiderin in any part of the brain, it causes some local magnetic changes in that area, and susceptibility weighted MRI is sensitive to that change. So it can pick up petechial hemorrhages, which can help you to diagnose cerebral amyloid angiopathy or diffuse axonal injury. So these are two conditions where we use susceptibility weighted MRI. Okay. This particular SWI is normal. This is a normal SWI image. This is normal SWI image as it is asked to identify in a previous AIMS exam question. Okay. Now one bacha was saying, sir, why can't we see the white matter damage directly? So I want you to see this particular image. Can you see here? This is a 2-dimensional image. This is a 3-dimensional image. You can see the brain white matter in this image. Everybody look at this image. Brain white matter is shown in different colors. You can see a red color, green color, blue color. Okay. So you can see the red is the commissural fibers. Commissural fibers. Green is the association fibers. And the blue is the projection fibers. I'm again repeating बेटा, I'm again repeating. मैं दोबारा repeat कर रहा हूँ. एक बार ध्यान से देखना. देखो, मैं कह रहा हूँ susceptibility weighted MRI के अंदर we can see hemosiderin, and so if there are tiny bleeds happening in brain at multiple times because of weakening of the vessels in cerebral amyloid angiopathy, you can detect it on SWI, and that is what I was telling at that time. And today we can not only see hemorrhage, we can also see the white matter tracts directly. In white matter, there are 3 types of tracts arranged in different directions. Commissural fibers are the one which are connecting the 2 hemispheres, like corpus callosum. Association fibers are which are connecting one part of the hemisphere with another part in that hemisphere, association. Projection fibers are going from brain downwards. Remember, corticospinal tracts are projection fibers. Today we can show them all using a MRI technique called as diffusion tensor imaging. What is the short form? DTI. DTI. Can you understand? Diffusion tensor imaging, DTI, can show us the white matter tracts. Today we can identify the white matter tracts on MRI technique called as diffusion tensor imaging. And like one bacha was saying कि sir white matter में injury हुआ, we have injury to the white matter in diffuse axonal injury. Can we see it directly? Yes, we can today see it directly also if you have diffusion tensor imaging available. So diffusion tensor imaging can show you white matter tracts, which can be used pre-operatively in patients with brain tumors to find out which tracts are damaged, which tracts are displaced. It can be used to study different psychiatric illnesses, because so far all our focus was on cortex. Remember, you were always talking about frontal lobe, parietal lobe, brain cortex, gyri, sulci, but we were forgetting that there are interconnections between the different part of the brain which are responsible for what we are, that is your white matter. Today, MRI with diffusion tensor imaging has developed the ability to show you the white matter. You can see for yourself that you can see different tracts. You can see the commissural fibers shown as red, association fibers shown as green, projection fibers shown as blue, and we can see different tracts on a MRI image. This is called as DTI, diffusion tensor imaging. Clear? So we can also see white matter tracts on MRI. I already told you MRI is more powerful than what we saw on CT. I'm repeating for everybody. MRI can show us the biochemical metabolites, that is called as MR spectroscopy. MRI can show us acute infarct of the brain by looking at the property of particle motion using diffusion weighted MRI. MRI can show us chronic old bleeds using SWI, which is susceptibility weighted imaging, and MRI can also show us white matter tracts using diffusion tensor imaging. Okay, clear? So if in a patient with brain tumor, before we go for a surgery, pre-operatively we do a diffusion tensor imaging to map the tracts. We want to see how the tracts are, where is the tumor, so that the surgeon can make a better plan. Okay? Okay? Clear? Now, so the 3D image, what we have done is in one particular tract has been, we have just shown one particular tract by, using computer software. So that is why it is not color coded. 2D image is showing the color code. Okay? Happy? Now, another question is functional MRI. Can MRI also tell you the function of the tissue? Okay, which part of the brain is doing what function? Can you see? The answer is yes, using a technology called as BOLD technique. MRI can do functional imaging using a technology called as blood oxygen level dependent technique. Blood oxygen level dependent technique. Okay, are you clear? What is BOLD? Blood oxygen level dependent technique. Now, I will take your doubts also, but I want everybody to stop typing for one moment so that you can focus on very interesting concept. Suppose I ask the patient in the MRI machine to do hand grasping. What is the patient doing? Hand grasping. So to do this, I need my contralateral motor area to activate and fire. Corticospinal tracts will fire and I can do hand grasping. Okay, my hand area should get activated. But if any part of the brain is active, it will consume more oxygen. If it is consuming more oxygen, the oxygen content in the blood will fall. So if I have a technique which can see it, BOLD. What is BOLD? It can see the blood oxygen level dependent technique. If the blood oxygen level falls, it shows that area as bright. Can you see this orangish area? This is your motor area. Similarly, now I am asking the patient inside the MRI machine to do this. Patient in the MRI machine is doing this. What is this? Finger opposition. Patient is doing finger opposition. So what is happening? Not only the motor area, even the supplementary motor area is getting activated, because this is more complex than hand grasping. I am doing finger opposition. I can see motor area is lighting up. Oxygen consumption is happening, and also the supplementary motor area is getting activated. Clear? Now try to understand now. I want you to speak and answer and let me know in the let everybody around in your house know that you are studying. Okay, answer bolna hai, main sun paunga. I have put some secret cameras when the mobile app was getting updated. I have put some secret audio in your phone now. Let me spy on you. Tell me, answer this question. Suppose in the MRI machine, I ask the patient to say A. Patient is lying in the MRI machine. I have switched on the bold technique and patient is saying A, and the bold is on. What will happen? The motor speech area will get activated and you will be able to delineate the Broca's area. Okay. Are you able to understand? So this is how functional MRI helps us to find which part of the brain is doing what function. It helps us to delineate motor and speech functions pre-operatively. Okay. Motor and speech functions, we can, suppose somebody has a brain tumor. You want to see that where is the motor area in relation to the tumor, where is the speech area, so that during surgery you don't damage these two vital functions. So pre-operative localization of motor and speech functions with respect to the tumor helps the neurosurgeon. So have you ever wondered that why neurosurgeons have become better now? Neurosurgeons have become better now because radiology has become better. Because we are able to guide them. Otherwise, sometimes if you have a large tumor, the surgeon is operating blindly. He takes out the tumor, also takes out the speech area also. And after the surgery is successful, but the patient cannot speak. But now this does not happen because pre-operatively we map the patient, we give him an image, we give the surgeon an image that देख भाई ये tumor है, speech area यहाँ पे है, motor area का activation यहाँ पे हो रहा है, so that he is careful during the surgery. Okay, and we can ask the patient to do different actions, and that part can be delineated. So it is also a research tool. It is a possible question for you in the exam that functional MRI is done with which technique? The answer is bold. What is bold? Blood oxygen level dependent technique. Okay, clear? Okay. Everybody, so we can do other areas also, but motor and speech. बेटा देखो श्रेया भट्टाचार्य, अब आई थिंक कई बार बच्चे ने देखा नहीं होगा भाई, सर्जरी के बाद आदमी चल ना पाए, बोल ना पाए, सबसे इंपॉर्टेंट बात होती है ब्रेन सर्जरी में ना. बाकी भी देख सकते हैं, बट इफ द पेशेंट इज नॉट एबल टू स्पीक, नॉट एबल टू वॉक, देन दैट इज अ बिग ब्लंडर ना. सो दैट इज द मोस्ट क्रिटिकल थिंग. ओके, नाउ आई विल शो यू वन मोर थिंग. ओके, आई एम शोइंग यू वन मोर इमेज. Everybody now, look at the screen of your mobile and tell me, please, everybody focus. Tell me, what are you seeing here? What is this body part? Label it for me. Exam is going on. This is a previous NEET PG question. MRI image, yes, but what body part? Let me help you. Everybody, this is a common bile duct. This is pancreatic duct. I know some of you were thinking brain na. One bacha was saying hippocampus. No, bache, this is not brain. So what happens is sometimes in the exam when we are talking about brain, suddenly I change gear, you might get confused. MRI has the ability to show me the bile duct and the pancreatic duct, that is called as MRCP. What is MRCP? Magnetic resonance cholangiopancreatography. What is MRCP? Magnetic resonance cholangiopancreatography. Okay. we are using MRI to look at the bile duct and the pancreatic duct. Okay, so you're using MRI. MRI is a non-invasive technique. No endoscopy is required to do MRCP. No radiation is required because MRI is based on magnetism. There is no ionizing radiation. Okay. So how we are able to see the ducts? How we are able to see the bile duct? Okay, I will explain to you. This is MRCP image. This is a special type of MRI. Listen to me very carefully. This is using no dye. No dye has been injected into the ducts. All we are using is a technique called as heavy T2 weighted images. What is the technique? Heavy T2 weighted images. Okay. Now everybody, just listen to me. Just keep your pen down. Listen to me. T2 weighted image में the water in the T2 weighted image was, tell me, white. If this is a heavy T2 weighted image, the water will become very, very white. So all we are doing is we are making the water in the bile juice, water in the pancreatic duct, water in the duodenum, water in the bowel. We are just making that water very bright by using MRI technique. We are making the water in the ducts very white, and we are making it so white that only the ducts which have water or fluid are seen. Rest of the tissues are not visible at all. Only we are able to see the ducts. That is called as MRCP. That is called as MRCP. I am repeating now. Everybody repeat after me. MRCP is non-invasive. No endoscopy is required. No radiation is there. No dye is required. It is just a heavy T2 weighted image. Now, because it is a non-invasive test, there is no endoscopy. It is usually the investigation of choice for bile duct stones, bile duct, common bile duct stricture, bile duct choledochal cyst, and pancreatic duct narrowing, which happens in chronic pancreatitis. I will explain this when we reach pancreatitis later on. But remember, with MRCP, listen to me everybody, listen to this line that I am saying. Isko suno ek baar. With MRCP, you can non-invasively see the bile duct and the pancreatic duct. तो बाइल डक्ट में स्टोन है, स्ट्रिक्चर है, सिस्ट है, या क्रॉनिक पैंक्रेटाइटिस में पैंक्रेटिक डक्ट में नैरोइंग है. यू कैन सी देम विद MRCP. Okay. Now one bacha is saying, sir, very good. Ashwin is a very smart boy. Ashwin Kumar, very good beta. Now Ashwin, tell me. Ashwin is predicting. Now twice he has predicted. This patient, I told this patient not to have anything before coming to me for MRI. He had a glass of water. He had a glass of water. And you can see that water in his stomach. So that is his stomach. It is becoming bright because of the water. And other things are nothing but those bowel loops also having a little bit of water. Clear? Now Rishabh is saying CT pe nahi dekh sakte. CT scan is a axial scanning of the abdomen. CT scan is inferior to MRCP to look for bile duct and pancreatic duct, because these are obliquely oriented structures in your body. Better to see them with a multiplanar technique called as MRI, special technique called as MRCP. Clear? Clear, bache? Okay, beta, very good. Everybody clear? How can we delineate the cyst? Okay, Kirti, let me explain to you. Kirti, beta, ek baat dekhna, just to make sure that you are able to understand. Kirti, please see. Okay, anybody? Anybody? Can you see now This is the bile duct which is having cystic dilatation. I have made it now. Can you see? Now I am removing it. Please see. Normal cystic dilatation. This is how a choledochal cyst will look like. Okay. Are you clear? And regarding pancreatitis, don't worry. I will spend around 20-30 minutes on pancreatitis when we reach there. Okay. I will talk about abdomen CT, MR, pancreatitis. I will talk about everything subsequently. अभी किसके बारे में बात करें? MRI. This is MRCP. But if it is so easy, why do students get it wrong in the exam? What is the confuser? Confuser is this image. Previous NEET PG image. Now tell me. This is not MRCP because you can see a endoscope. Can you see? This is an endoscope. This is a technique called as, anybody? ERCP. This is a technique called as ERCP. What is ERCP? Endoscopic retrograde cholangiopancreatography. Now immediately the question is, okay, ERCP, invasive, non-invasive. It is a invasive technique. We need to do endoscopy. Okay, so we have put an endoscope. Now this endoscope is special. Normally in endoscope the camera is at the end. In normal GI endoscopy the camera is at the end. In ERCP camera is on the side. It is a side viewing endoscope. Using this endoscope, you are using this endoscope to inject dye into the bile duct and into the pancreatic duct. So you have injected the dye endoscopically. So dye has been injected endoscopically into the ducts. After injecting the dye, you have taken a X-ray. Okay, try to understand. You are doing endoscopy, injecting the dye into the ducts, taken the X-ray of the body. Now that means there is radiation being used to do a X-ray. Okay, so ERCP is opposite of MRCP. MRCP non-invasive, ERCP invasive. Type of endoscope, side viewing. Dye is required, radiation is there. Okay. If there is any procedure to be done, you can do it when doing ERCP. ERCP has the advantage that while doing ERCP, if any procedure has to be done, you can do it through the endoscope. So it helps you to plan and do the procedure side by side. But can anybody tell me, listen to me, so it can be therapeutic also. Very good, Monisha. It can be therapeutic also. But tell me, beta, if I am doing ERCP and I am injecting the dye into the pancreatic duct, if you inject the dye into the pancreatic duct with force, what will happen? You will damage some pancreatic side branches. The pancreatic juice will leak into the parenchyma, cause some autodigestion of the pancreas. It can lead to pancreatitis. So you have to be very careful when we are doing ERCP because it can lead to pancreatitis if you are using unnecessary force while doing the ERCP procedure. Clear? You can even remove the stones using during ERCP. So ERCP, the main advantage is you can do procedures when you can perform a procedure. With MRCP, you cannot perform a procedure. So in the exam, they confuse you between MRCP, where there will be no endoscope, and ERCP, where you can see the endoscope. And third is this. Sometimes they will confuse by saying, "Acha, ye bata, is this MRCP or ERCP?" It is none of the above. It is a separate investigation which is called as T-tube cholangiogram. ये कंफ्यूज करने के लिए रखा मैंने. ये टी ट्यूब कोलेंजियोग्राम है. दिस इज डन आफ्टर cholecystectomy. In some cases, after cholecystectomy, if the surgeon feels during the gallbladder removal, surgeon thinks that there is some problem with the bile duct, he leaves a T-tube for further evaluation inside. So, and we are injecting dye through this T-tube. This is the T-tube. Okay, so the dye has been injected through a surgically placed T-tube to do the T-tube cholangiogram. So T-tube cholangiogram is different from MRCP. Don't get confused in the real exam. Okay. Now Sangram was saying, sir, retrograde क्यों कहते हैं ERCP को? देखो, we are injecting the dye opposite to the direction of the bile flow. Bile flow का direction ऐसे है और dye उसके opposite direction में जा रहा है. So we are injecting the dye opposite to the direction of the physiological bile flow. So we call it retrograde. Okay. Everybody clear? Okay. Everybody clear? Okay. Very good. So sometimes we get confused with this. Second part they can confuse us with is this. I want all of you to look at these two images. Okay. There is a special MRI technique called as time of flight. Okay. There is a special MRI technique called as time of flight, which shows the blood flow as white. Okay. Dekho, remember I told you in routine MRI, flowing blood will be dark. Remember flow void? Routine MRI में तो blood flow dark होता है. But special MRI technique है, इसका नाम है time of flight. There is a special MRI technique called as time of flight in which blood flow is white. So it can be used to do two investigations. This is MR angiogram where we can see the blood vessels, arteries of the brain. And if we use time of flight technique for slow flow, we can do MR venogram. We can do MR venogram. Clear? Okay. देखो, ये MR angiogram है. They might ask you to identify in the exam. This is MR angiogram. And immediately you might say, sir, ये CT क्यों नहीं है? Why this is not a CT angiogram? Again, go back to the basics. This is your bone. This is your skull bone. This is the fat in the orbit. What is the color of the bone? The bone is dark. The fat is white. This must be MRI. If this was CT, the bone should be white. यहाँ पे bone dark है. This is MRI. Arnav, are you clear now? Okay, this is MR angiogram. Okay, how will they make a question on it? Let us look at some questions one by one. First question. A patient has autosomal dominant polycystic kidney disease. A patient has autosomal dominant polycystic kidney disease. You want to do screening of his brain for some pathology. What investigation will you use to do what? देखना क्या चाहते हैं? Polycystic kidney disease में brain में क्या हो सकता है? Anybody? I'm again repeating. Routine MRI, blood flow should be dark. But a special MRI technique called as time of flight shows blood flow as white. That is called as MR angiogram. Question is, in a patient with autosomal dominant polycystic kidney disease, you want to screen his brain for what? We know autosomal dominant polycystic kidney disease is associated with cerebral berry aneurysms. Okay, this patient could have a berry aneurysm. Okay, association. He is not symptomatic. We want to do screening. Screening समझते हैं ना? Screening is done in people who are at high risk for having a disease, but right now they are asymptomatic. So we have time. We want to use something which is totally harmless. That is MR angiogram. However, if they will say, what is the investigation of choice for cerebral aneurysm? When will you do investigation of choice? When the patient is symptomatic. What symptom? Subarachnoid hemorrhage. Worst headache of his life. Life-threatening condition. IOC for cerebral aneurysm? CT angiogram. Screening for cerebral aneurysm? MR angiogram. Everybody clear? Everybody able to answer this? Everybody able to answer this? That screening for cerebral aneurysm should be done with MR angiogram, but investigation of choice is CT angiogram. Confuser. Many times people do it wrong in the real exam. Second question is, they might ask you to identify the normal anatomy. I will ask you one by one. Identify the blood vessel labeled by number 1. Anybody? Identify the blood vessel labeled by number 1 in the image. What is number 1? Internal carotid artery. That is your internal carotid artery. Number 2. Number 2 is the middle cerebral artery. Number 3 is the anterior cerebral artery. Anterior cerebral artery. Number 4 is the vertebral artery. Number 5 is the basilar artery. Number 6, posterior cerebral artery. Number 7 is posterior communicating artery. So sometimes they might ask you just a simple identification. They might say internal carotid artery pehchano, so that is at 1. They might say where is middle cerebral artery? Middle cerebral artery is at 2. Where is anterior cerebral artery? Number 3. They might say where is vertebral artery? Number 4. Where is basilar artery? Number 5. Where is your posterior cerebral artery? Number 6. Where is your posterior communicating artery? Posterior communicating artery is at number 7. Everybody able to understand? Okay. Everybody follows? Okay. This is a normal MR angiogram. There is no twisting here. This is normal angiogram. Okay. I will show you abnormal also. Beta. Abnormal दिखाऊंगा. ये मैंने बुक में नहीं दिया क्योंकि मैं चाहता था आप आज देख के बताएं. Okay. So let's see. Anybody can look at this. This is your internal carotid artery. Internal carotid artery. दोनों तरफ पे. Now look at this area. What has happened? We can see the internal carotid artery till a level, then it looks occluded. So there is bilateral ICA stenosis. Okay. Internal carotid artery is stenosed. But we can see the anterior cerebral artery, we can see a lot of distal vessels which are formed from collaterals. What has happened is, there is idiopathic stenosis of the internal carotid artery. From the posterior circulation, there are collateral formation, which is now forming the ACA and the MCA are formed by the collateral. So there are a lot of collaterals. These collaterals, if you look closely, they look like these collateral, look like a lot of, vessels, just like smoke. They look like a puff of smoke. This condition is called as moya disease. What is moya? It's a Japanese word for smoke. So remember, what is moya disease? It is idiopathic bilateral supraclinoid ICA stenosis, which leads to collateral formation, which is called as puff of smoke appearance, which is seen in moya disease. Moya means smoke, dhua, moya. Clear? So again, so that is the value of knowing the anatomy. That once you see that, achha, dekho, dobara se dekho mere saath. This is how the normal internal carotid artery should look like. Okay? And see the abnormal now. If you want, you can take a picture of me here. Dekho yahan pe, iske saath khich lo. Okay? Yahan pe. So you can see the ICA is narrow. And you can see the collaterals forming the distal circulation. This is called as the puff of smoke appearance of moya. Yes, I told you, this image is not there in the workbook because I wanted to keep it for secret for the class, so that when you come to the class, you should get something extra. है ना, ऐसा होता है क्लास में कुछ मिलना चाहिए ना. That's the entire idea. Okay. Now, one more question. Where are the collaterals coming from? Manish is saying collaterals are coming from the posterior circulation and also from the meningeal circulation. Remember, meninges को external carotid artery supply कर रही है, तो वहां से भी आएंगे, और collaterals are coming from the posterior circulation as well as the meningeal circulation. Now, see the vein. Okay, see the vein. Vein देखो मेरे साथ. So in the brain you also have veins. try to imagine and identify some of them. Identify the vein marked here, superior sagittal sinus. What is the red colored arrow here? Vein of Trollard. What is this sinus here? Straight sinus. What is the blue arrow? Vein of Labe. Transverse sinus. Sigmoid sinus. And this particular vein that you see here is vein of Galen. Great vein of Galen. Okay. This is the clear. This is a MR venogram. Let me just show you the image again. This was the Moya disease that we were looking at. Okay. Now, bacha, please tell me. So, where will you use MR venogram? MR venogram is the investigation of choice for cerebral venous thrombosis. Remember, CT scan pe we get suspicious, we can get a doubt that there is thrombosis if we see the delta sign. But how will you confirm? You will need to do a MR venogram. Investigation of choice for cerebral venous thrombosis is MR venogram. One more condition in which MR venogram helps is this. I will give you a quiz. I want all of you to look at this MRI image without me. Spend your time looking at the image. This is a MRI of an infant who has a large head and heart failure. Large head and heart failure. Okay. Okay. What could it be? Why this infant has a large head and heart failure? Okay. This patient has a congenital AV fistula, arteriovenous fistula in his brain, in a vein called as median prosencephalic vein. Photo le lo iski bhi. Median prosencephalic vein. Now suppose, now everybody listen to me, artery or vein fistula. That means artery and vein are abnormally connected. So the blood from artery will go into the vein will become dilated. So this area is a vein which is all dilated. Now this median prosencephalic vein will form, is supposed to form the vein of Galen. Lekin if there is a there is a AV fistula here, it becomes malformed. This is called as vein of Galen malformation. You might have studied this in pediatrics also. You might have seen this in pediatrics also. Now my question is this. एक बात सारे बच्चे देखो. Look at the midbrain. And some bachas are saying, sir, I can't take a picture, then what happened? But I will leave the entire video with you. Don't worry. After you want to revise anything, just quickly do it in 2x and revise it. Look at the midbrain. This dilated vein of Galen, this vein of Galen malformation is compressing the midbrain. And what is passing through the midbrain? Aqueduct. If aqueduct is compressed, what will happen? Hydrocephalus. If you have hydrocephalus, what will happen to your head? Large head. I told you in the question, large head. But why heart failure? If you have an arteriovenous fistula, you might have read about this in physiology. AV fistulas are an important cause of high output cardiac failure. So because vein of Galen malformation is nothing but a congenital arteriovenous fistula, it predisposes the infant to heart failure. So that is why this patient had two features written in the question: large head and CHF, high output cardiac failure. If you auscultate his head, you will hear a cranial bruit. If you auscultate his head, you will hear a cranial bruit. So important thing to remember here is investigation of choice for vein of Galen malformation is MR venogram. MR venogram also helps us to diagnose in pediatrics vein of Galen malformation. When will you suspect vein of Galen malformation? When you have an infant with large head and heart failure. This combination mark the answer as vein of Galen malformation. 100% correct answer in the exam. Okay, so I'm again repeating for the bachas who could not pick up. देखो, embryologically there is a vein called as median मतलब midline में रहेगा. Prosencephalon मतलब forebrain का vein है. Median prosencephalic vein, which is a precursor of vein of Galen. That means this vein is going to form vein of Galen. But suppose you have a intrauterine life, you have a arteriovenous fistula in this area. What will happen? The vein will get all malformed. So vein of Galen will be malformed and dilated. It will compress the aqueduct, cause hydrocephalus. It will cause AV fistula, will lead to high output cardiac failure. It will cause a cranial buoy, and that is what is called as vein of Galen malformation in your pediatrics. Can you see integration happening? How to tell this is vein of Galen? This is the anatomical location. This is where vein of Galen is located. Just remember, अभी मैंने दिखाया था ना, ये होता है vein of Galen बेटा. ये. This is the area of vein of Galen. ये वाला. Okay. So Rishabh is saying, sir, एक बार MR venogram भी दोबारा दिखा दो. I will do it again. Everybody now, everybody on your marks. Let's play it again. Look at the sinus. What is the sinus? Superior sagittal sinus. What is this vein? What is this vein? This is vein of Trollard. What is this sinus? Straight sinus. What is this vein? Vein of Galen. Vein of Galen. What are these? Internal cerebral veins. Do you remember I taught you in the previous class? Internal cerebral veins will join to form the vein of Galen. This is your vein of Labe. These are your transverse sinus, sigmoid sinus. Okay. Now Samruddhi, median prosencephalic vein, vein of Galen का precursor है, मतलब उससे पहले है ये, तो इसलिए हम इसको vein of Galen malformation कह रहे हैं, क्योंकि that is not getting properly formed. Okay, so where is the inferior sagittal sinus? Ritik has asked this question. So inferior sagittal sinus is often absent in many people. जैसे in this particular case it is absent. It is a normal phenomena. Inferior sagittal sinus is I think in 1/3 of people it will be absent. So it is very common to be absent. But in anatomy they don't tell you. So that's why you're getting confused. Clear everybody? Everybody? Okay. We can do a CT scan also, but MRI is going to show us better anatomy. You can see the detail that you see on MR venogram. So there are questions on MR angiogram, MR venogram, and two conditions I have taught you here. Screening for cerebral aneurysms, investigation of choice for cerebral venous thrombosis. I have also talked about Moya-Moya disease. Investigation of choice will be MR angiogram in Moya-Moya disease, and I have already talked about vein of Galen malformation. Okay, clear? Integrated? Okay. Now what we will do is, I will now show you some very, very interesting things that you have only heard of, but you may not have seen. MRI can show us other body parts, especially joints. I will show you some joints. Let's see how many of you can identify. Which joint do you think is this? Which joint? Some of you are thinking, is this corpus callosum? No, this is a joint. Tell me. So this is your knee joint. This is your knee joint. Okay. Now one bacha is saying, कि sir ये knee CT है क्या MRI है? Is this CT or MRI? So look at the color of the subcutaneous fat. Look at the color of the fat. Look at the color of the fat. Look at the color of the bone marrow fat. Okay. So what is the color of fat? Fat is appearing white. Fat is appearing white. What is this? This is your muscle. And if you look closely, the outer part of the bone, which is your cortex, is appearing dark. So important thing to understand is, in this particular image, it is a MRI. Why? Because the cortex of the bone is dark. Don't get confused when you see the fat in the bone marrow or fat in the subcutaneous tissue. Fat will be white. Now I hope now it is clear to you. When I was showing you this brain image, one bacha was saying, sir, clivus mein fat kyun hai? Because you have bone marrow there also. In the skull base you have bones, have bone marrows that can have some yellow marrow tissue that is causing that white appearance. Remember, bone marrow has red marrow which is hematopoietic, yellow marrow which is fat. So that fat in the bone marrow is causing this appearance. So many children get it wrong. They get confused. So this is not a CT scan. This is MRI. Clear? Okay. Now anybody, I will ask you a question. I am going to ask you a question on your marks. On your marks. देखते हैं कौन पहले बताएगा. Can you see this bow tie shaped dark black structure here? Shaped like a bow tie. What could it be? Okay. What could it be? This is your medial meniscus. This is your medial meniscus. So just to remind you, if you look at a meniscus from the top, this is how the meniscus will be. Remember, a C-shaped structure, fibrocartilage that you might see in your knee anatomy. This is how it looks like. Okay. So in MRI, I am taking a sagittal section through this area. Okay. So this is the body of the meniscus. This is the anterior horn. This is the posterior horn. So when I take a section through the body of the meniscus, it looks like a bow tie. It looks like this. Bow tie appearance is normal appearance of the meniscus. This is normal. So if bow tie is not seen, think of a tear. This is normal appearance. Question is this, beta. If I take a section through this area, what will happen? If I take a section through the anterior horn, posterior horn, I want you to see the image. I am zooming it. This is your femur. This is your tibia. Are you able to see one dark triangle here and one larger dark triangle here? Can you see? This is your anterior horn of the medial meniscus, posterior horn of the medial meniscus. Clear? Everybody understands? Clear, beta? Okay. Now I will show you one small thing. Anterior horn is smaller, like Shubham is saying. Posterior horn is bigger. That is normal. It is normal in medial meniscus. Medial meniscus में anterior बड़ा होता है, posterior छोटा है. Posterior बड़ा है, anterior छोटा है. So this is normal medial meniscus where anterior horn is smaller, posterior horn is larger. This is normal. But I want you to answer one very difficult question, beta. Very difficult question coming your way. Can you see between the cortex of the bone? Can any of you tell me between the cortex of the bone and the meniscus, can you see some soft tissue in between them? Can you see some soft tissue sitting here? Okay. I will try to remove myself so that you can see a clear view. See the yellow dots between the cortex of the bone, which is dark and black. Can you see these tiny yellow dots? There is some soft tissue there. What is this? Anybody? That is your articular cartilage. That is your articular cartilage. Remember, your joints are covered by a hyaline cartilage called as the articular cartilage. So if they say articular cartilage, investigation of choice, MRI. Are you clear बेटा कि नहीं? समझ आया कि नहीं कि एक्सरे पे कार्टिलेज नहीं देख पाते? We cannot see the cartilage X-ray. That is why when you were in your first year MBBS, they showed you X-ray of the knee and they said space between femur space. But असली में तो there is no space. In real life, there is no space in the joint. There is cartilage, but cartilage is not seen on X-ray, it is seen on MRI. So, previous question. Investigation of choice for articular cartilage in the knee. MRI. Because MRI can show us cartilage. Now, one bacha will be saying, sir, meniscus bhi cartilage hai, articular cartilage bhi cartilage hai. Why they are appearing different? Why there is a difference in appearance? Why is the meniscal cartilage more dark as compared to articular cartilage? Because there are different types of cartilages. Articular cartilage is a hyaline cartilage, while meniscal cartilage is a fibrocartilage. So they have a difference in their constitution. That is why they are appearing different on MRI. This is the power of MRI. Can you see it here? Now, one corollary, one ENT question coming your way. if laryngeal cancer invades the cartilage, how will you see? Which investigation? So let me ask you a ENT question. What investigation can see the laryngeal cartilage invasion in CA larynx? Just like you saw a question this year in the INI exam, that if the laryngeal cartilage is invaded, it becomes T4, but how will you see that invasion? MRI is better than CT. Why? Because cartilage is better seen on MRI. MRI can evaluate the soft tissues. It can see the cartilage. Everybody clear? Everybody able to answer my concepts? Okay, beta, very good. I can see so many intelligent students. I'm telling you honestly, you are the best superlative batch that I've ever taught in my life. Most intelligent students. Very good. Now tell me, as I go more medial, this is your femur, this is your tibia, this is your cortex of your bone, this is your bone cortex. Can you look at a dark black structure? These are sagittal sections of the knee, beta. I think one bacha is saying, Joel and everybody is saying, sagittal sections of knee ka. Can you see a dark rubber band like structure? ये देखो ये वाला. Can you tell me what is it? Is it a tendon? Is it a ligament? Can you see this dark rubber band like structure here? Yes. Connecting femur to tibia. It is connecting femur to posterior part of tibia. Femur to posterior part of tibia. So if it is connecting bone to bone, it must be a ligament. It is connecting it to the posterior part of the tibia. Posterior cruciate ligament. पीछे वाला posterior cruciate ligament. Are you able to identify the exam? Okay. So any fibrous structure will be dark on MRI and it will be connecting bone to bone, ligament. Muscle to bone, tendon. So this must be a ligament, bone to bone, connecting to the posterior part of tibia. Posterior cruciate ligament. Everybody understands? Very good. But in the exam they will ask you the other one. Please see with me. We are again taking another sagittal section further medially. This is your femur, tibia, patella. I want you to see a dark rubber band like structure in the intercondylar notch connecting the femur to the anterior part of tibia. Can you see it here? The yellow lines. Follow the yellow lines. Can you see this? From the femur in the intercondylar notch to the anterior part of the tibia. This particular ligament. Very, very important question. Footballer's injury. What is this? ACL. Anterior cruciate ligament. Anterior cruciate ligament. Ab trick samajh aa gaya na? The ligament which is inserted in the anterior part of the tibia is ACL. Posterior part of tibia is PCL. Why cruciate? Because they are crossing each other. That is why we are calling them cruciate ligaments. Okay? Everybody clear? Okay. One more question. अभी खत्म नहीं हुआ. एक क्वेश्चन और अभी बताना है. Okay? Femur, tibia, fibula, patella. Can you see between the femur and the tibia? You can see two dark triangles. Two dark triangles. These are your lateral meniscus. These are your lateral meniscus. मैंने बताया था ना, all fibrous tissue, ligament, tendon will be dark on MRI because of fibrous tissue. So these are your lateral meniscus. Why is the femur white? Because of the bone marrow fat. I told you multiple times a class been. Remember, bone में cortex MRI पे dark है, लेकिन bone marrow because of the yellow marrow, the fatty component looks white on MRI. Now question is this. Lateral meniscus. Anybody? Lateral meniscus क्यों है? Why this is not medial meniscus? Why this is not medial meniscus? Why lateral meniscus? Can anybody tell me the reason? Because you can see the fibula. If you are taking a sagittal section which is showing you the fibula, it must be the lateral compartment. Clear? And the anterior and the posterior horn are equal also. That is also a pointer towards lateral meniscus. Everybody able to answer? Clear? Are you able to do it? ओके बच्चे, वेरी गुड. ठीक है. अच्छा, एक और बताना है अब इसको देख के बताना है आप. ठीक है. वी विल ट्राई टू लुक एट MRIs ऑफ डिफरेंट बॉडी पार्ट्स. लाइक वी हैव ओनली मेनली सीन द ब्रेन, देन आई टुक यू टू MRCP, देन आई एम टेकिंग यू टू नी. ग्रेजुअली वी विल ट्राई टू कवर मोर ग्राउंड एंड सी मोर एंड मोर आइडियाज. दिस इज अ कोरोनल. अभी तक जो देखा था सब कुछ सैजिटल था. All the sections that we saw so far were sagittal. This is coronal MRI of the knee. This is your femur. This is your tibia. Okay, एक बार देखो. This is your subcutaneous tissue. This is your subcutaneous tissue. Anything abnormal or anything unusual that you see on this MRI? Okay, this is a knee joint. Definitely you can see the knee joint coronal image. Put the chat box on fire. Let me know कि इसमें कुछ अलग है. क्या अलग है ऐसा? What is the difference on this MRI that is different from all other MRIs that we saw so far? Anybody can guess and tell me. The fat is all suppressed. Did you notice or not? That the bone marrow fat is suppressed. The bones are looking absolutely black. The soft tissue and the subcutaneous tissue all black. The fat is suppressed. Okay, so this is a fat suppressed MRI image, which is called as, the technique is called as STIR. Technique is called as STIR. What is STIR? They will not ask you the full form, they will only say STIR, but just for the sake of completion I am telling you, STIR is a fat suppressed technique which can be written as short tau inversion recovery sequence. Short tau inversion recovery sequence. Okay, so if you suppress the signal of fat in the bone, what happens is it makes it easy to see any patient having bone marrow edema. It makes it easy to appreciate bone marrow edema, which otherwise was difficult. If you do a normal MRI, the bones will be white because of bone marrow fat and you cannot pick up edema. But if you suppress the fat signal, if there is any area of edema, it will be seen easily. And how that will help us? Try to imagine now. If you have a patient with acute osteomyelitis, if you have a patient with acute osteomyelitis, what is the investigation of choice? The answer is MRI. Why? Because MRI can show us marrow edema as early as 24 hours of onset. You will read this in orthopedics again. That osteomyelitis में सबसे पहले कौन सी investigation बता सकती है कि हड्डी में infection है? Which is the investigation which can tell you that there is infection in the bone? Answer is MRI. How early? As early as 24 hours. MRI can pick up bone marrow edema by using a MRI sequence called as STIR, which is suppressing the signal of the fat to make it easy to appreciate bone marrow edema. Second such indication that they will definitely ask you in the exam is stress fracture. Now in stress fractures, sometimes the cortical break. In stress fractures, you might have studied in orthopedics, they might have talked about march fracture. Somebody is doing marching and the metatarsal has fracture. But remember, stress fractures, sometimes the cortical break, the cortex break is very, very microscopic and cannot be seen. But if there is an injury in that area, जहां पे चोट होगी वहां पे सूजन हो जाएगी. In that area, if there is injury, there will be edema, and that can be picked up on MRI. That is why stress fracture also investigation of choice is MRI. Okay, are you clear? So if we suppress the signal of fat, if still the bone remains white, नील राठौर बेटा, नील एक बार सुनो बात को, है ना? अगर हड्डी में, if you have suppressed the signal of fat, still that bone area remains white, that means that is edema. That could be a tumor, that could be infection, that could be trauma. बिकॉज सूजन क्यों होगी? या तो चोट है, इन्फेक्शन है, ट्यूमर है ना? तो एक्यूट ऑस्टियोमाइलिटिस इन्वेस्टिगेशन ऑफ चॉइस एमआरआई, स्ट्रेस फ्रैक्चर एमआरआई, बिकॉज एमआरआई कैन पिक अप बोन मैरो इडीमा. Also remember one more line important for you to remember is, for any problem in bone marrow, MRI is better than CT. Any problem in bone cortex, CT is better than MRI. Bone marrow better evaluated on MRI, bony cortex better evaluated on CT. Okay, everybody follows? Everybody follows? Okay. Now, if I show you a little bit more images, I know some of you are getting hungry, and that's a good sign that your brain cortex is consuming some glucose, but we will come to a break at a certain point because we have to cover something before the break. Okay, just very, very important things to do together. Otherwise, you will get confused. Is this knee joint, beta? Ab batao. Okay. Is this knee joint? Okay, this is not knee joint. This is a shoulder joint. Some bacha was asking regarding rheumatoid arthritis imaging, etc. We'll talk about this at length when I talk about joints and bones. I'll talk about it. Don't worry. This shoulder. So in shoulder, are you able to identify? This is a coronal MRI image of the shoulder. This is your humerus. This is your glenoid process of scapula. The important structure here is this. This is your supraspinatus muscle belly. Can you tell me what is this structure connecting the supraspinatus muscle to the greater tubercle of the humerus? Can you see this structure here? Connecting the muscle to the bone is tendon. What is this? Supraspinatus tendon. What is it forming? It is forming the rotator cuff. Commonly torn muscle tendon in rotator cuff, supraspinatus. Rotator cuff tear, investigation of choice. Anybody? What is the investigation of choice for rotator cuff tear? Anybody wants to tell me? MRI. First step to be done. First investigation to be done. First investigation to be done in suspected rotator cuff tear is ultrasound. Now remember, two different questions, don't get it wrong. Investigation of choice is MRI. You can see yourself how easily we can see the rotator cuff. But normally in OPD, first thing you do is you ask the patient to stand like this and you put an ultrasound machine to see the tendon. So first step, first investigation in a patient with suspected rotator cuff tear should be ultrasound. But if they say IOC, please mark MRI. Shoulder MRI is also indicated in recurrent shoulder dislocation. Any one of you can tell me what is that cartilaginous structure which is giving stability to the shoulder joint, which is that is called as glenoid labrum. Any one of you can tell me if the glenoid labrum antero-inferior tear in a patient with recurrent shoulder dislocation, what is that called as? On MRI, if you have a patient who has recurrent shoulder dislocation and you see antero-inferior tear in the glenoid labrum, what will you call it? What is the name? What did you read in orthopedics and anatomy? That is called as Bunkart's lesion. That is called as Bunkart, and that is a cartilage. Again, you can see the value of MRI. X-ray and CT can only show if it is a bony Bunkart's. That means if the glenoid bone is broken, you can see it on X-ray. But if it is only a cartilage antero-inferior labral tear, you can see it on MRI. So role of MRI in shoulder is to see rotator cuff injuries, to see glenoid labral integrity in patients with recurrent shoulder dislocation. Okay, and I can see, there are some tiny little things that I want to tell you before I send you for a break. So please bear with me. Look at this body part and tell me, what body part is this? This is your lumbar vertebra 5, lumbar vertebra 4, lumbar vertebra 3, lumbar 2, lumbar 1. What is this? MRI of the spine. You can see the lumbosacral spine. Now, on the spine image, how will you identify T1 and T2 weighted image? Spine में कैसे पता चलेगा T1 कौन सा T2 कौन सा है? I want you to look at the dural sac. I want you to look at the dural sac and look at this area. Okay, last image, and I think at this point we can take a break. Okay, this is the sagittal section of the spine. Always look at the dural sac. The CSF is dark, T1 weighted image, CSF is white, T2 weighted image. So, we can see many children are asking for a break. So maybe this is a good time to take a break. How long do you want to take a break, and at what time will you come back? At what time will you come back? So I can see one bacha is very hungry. I will show you disc also after the break. Don't worry. I'll show you the disc also. So maybe let's come back in 25 or maybe 20 minutes will be okay. Okay. So you can take a 20 minutes break, come back, and I'll start with the spine again. I'll show you how the spine, how the disc looks like, and I'll also talk about what to remember in spine. I will also show you other parts. I'll show you some pelvic MRIs, some contrast material, and then I will, in the end of the class, I will make sure that you start looking at diseases. So that is my goal for today. Come back in 20 minutes. So what we'll do is I'll just recap some things for you so that you get a flow of the class. So what I did was, in MRI, I showed you how to look at the MRI of the brain. I showed you different planes, different sequences. I made you familiar with the words T1 weighted image, T2 weighted image, flare, sagittal, axial, coronal. Then I showed you diffusion weighted MRI, susceptibility weighted MRI, MR spectroscopy, MR CP, MR angiogram, MR venogram. We also saw diffusion tensor imaging. We saw a lot of different mold technique, functional MRI, and then I gradually shifted to other body parts like knee joint. And one बच्चा was saying कि sir, जब meniscus दिख रहे हैं तो हमें ACL, PCL क्यों नहीं दिखता? So I thought I'll explain it to you that ACL, PCL is seen in the area of the intercondylar notch. And this is where you have the lateral meniscus, if you remember from anatomy. So ACL, PCL are in the intercondylar notch, and menisci are on the either side. So when we take a section through the intercondylar notch, you see the cruciate ligaments. And so this is what we were seeing so far in the class. And then we also looked at the value of MRI in the patients with acute osteomyelitis, in stress fractures, and we discussed that how to see bone marrow edema by suppressing the fat signal using a technique called as STIR. And then I went on to talk about the shoulder MRI, rotator cuff tears, shoulder instability, role of MRI. This is where we were, and that is the point when some of you felt a little hungry, and we were trying to get into the MRI of the spine. So this is how MRI of the spine looks like. Okay. Now Syani Chakravarti saying synovial membrane nahi dikhega kya? Synovial membrane will not be seen, but if there is synovial fluid, then you can see it. So you need some fluid in the synovial cavity to see that membrane, and if it is thickened, then you might see it, but not normally. It is not a usual thing that they will ask you in the exam. Okay. Now please see and understand. This has MRI T1 weighted image, and this other one is the T2 weighted image. How to differentiate? Look at the CSF in the dural sac. The CSF is dark, T1, CSF is white, T2 weighted image. CSF is white, T2 weighted image. Okay. Now this is where we were, and I saw some bachas were asking, sir, what about the disc? So this is your intervertebral disc, and this is your intervertebral disc. I want you to see on a T2 weighted image, intervertebral disc has a dark periphery and a bright center. If you notice carefully, intervertebral disc has a bright center on T2 weighted image due to nucleus pulposus. The pulpy part of the disc is nucleus pulposus, which is a notochord remnant. So that the arrow is at the nucleus pulposus, and surrounding it you will see some dark outline, that is your annulus fibrosus. So on MRI, in a normal person, disc will appear bright in the center because of nucleus pulposus. With age, this nucleus pulposus becomes more and more dry, it loses water, it becomes more and more darker. That is what you might have seen in some of your patients. But important thing to remember here is, okay, all spinal imaging, anything to do with spine and vertebra and disc, MRI should be the investigation of choice. Suppose you have a patient with prolapsed intervertebral disc. What investigation will you advise? MRI. Suppose you have somebody with pot spine, TB of the spine. What will you do? MRI. Suppose you have somebody with a spinal cord tumor. What will you advise? MRI. So anything to do with spinal imaging, I am again repeating, anything to do with spinal imaging, vertebra, disc prolapse, fracture of the vertebra leading to some cord compression, spinal cord, whatever you want to see in the spinal cord or in the spinal column, MRI is the preferred investigation today. Another thing to remember is, now Joel Lewis is saying T1 पे डिस्क क्यों नहीं वाइट है? बच्चे मैंने अभी तो बताया ना कि T1 weighted image पे water will be dark. Nucleus pulposus is a watery jelly like structure, so it is dark on T1. If you notice here, the disc is dark on T1 and it is bright on T2 because of the water content. Water is dark on T1, bright on T2. What is PIVD? PIVD is prolapsed intervertebral disc. What is PIVD? Prolapsed intervertebral disc. Disc prolapse. Okay, you might have seen some of your, some colleague of yours who goes into a gym, sometimes come back with backache and you get a MRI done, you discover PIVD. It is all possible. Prolapsed intervertebral disc. Okay, bache? Okay. Now let's do an axial section through the spine. If I take a section through the disc, I want everybody to focus on the section. If I take a section through the disc, the outer dark thing is your annulus fibrosus. The inner white thing is your nucleus pulposus. So this is, we are going through the disc. I want you to see so this is the area of the disc. This is the CSF sac. If you notice the CSF sac, the dural sac, I'm zooming in. I want you to see in the CSF sac, the CSF is white. The CSF is white. Tell me why? Why is the CSF appearing white? Because this is a T2 weighted image. CSF is white. But other than CSF, can you see these dots? What are these white, dark dots in the CSF? In the lumbar spine. These are your cauda equina nerve roots. So try to imagine this here. I am sure, with your understanding, you should be able to pick it up. So this is the area of your spinal cord. I am trying to zoom in. Spinal cord till here. Can you appreciate till L1, L2 you can see the spinal cord, and after that you cannot see it because at that level the spinal cord terminates as conus medullaris, and after that there are nerve roots. So if you take a section at the lumbar level, you can see the cauda equina nerve roots, which will be seen on an axial section like this. Can you see them? So what I'm trying to say here is, I'm saying to see the nerves or nerve roots, again MRI is the investigation of choice. Any problem with nerve, if you want to see it structurally, if you want to see a problem in the nerve, you need to do a MRI. For example, sometimes they will ask you in the exam in ophthalmology, what is the investigation of choice for optic neuritis? CT or MRI? What do you think? Now, what investigation can show you nerves and inflammation of the nerves? It has to be MRI. Suppose they say, what is the investigation of choice in a patient with retinoblastoma, where we want to see the involvement of optic nerve? So in retinoblastoma, when we do radiology, we want to see if the optic nerve is involved or not. What investigation you will do? you will do MRI. Are you able to understand? Suppose they say a patient has Pankos tumor. Suppose they say a patient has Pankos tumor, which is nothing but the apical lung apex tumor in the lung apex, which involves the brachial plexus. Suppose you have a Pankos tumor involving the brachial plexus. How will you diagnose it? MRI. So the moral of the story is, anything to do with nerves and spine, if you have to do a structural investigation, go with MRI. Anything to do with ligament, tendon, meniscus, cartilage, MRI. Anything to do with bone marrow, MRI. Anything to do with bone cortex, CT. Calcification, CT. Acute brain hemorrhage, CT. Subacute chronic hemorrhage, MRI. Diffuse axonal injury, MRI. I hope you get the concept of investigation of choice I am trying to build up in the side by side panel of yours. Not only this, always remember, in upper abdomen, there is a lot of respiratory movement. Okay. So in the upper abdomen, the respiratory movement is there. In pelvis, there is no respiratory movement. So what happens is, in upper abdomen, we prefer CT because CT takes less time to do. MRI is a longer investigation, so it is affected by respiratory motion. So usually, I'm saying usually, not 100%, but usually, upper abdomen I will talk more in CT. Pelvis, I will talk about MRI. Pelvic imaging, think of MRI. This is urinary bladder. Okay, this is urinary bladder. Okay, everybody look at it. In a female, the bladder is appearing white because of the urine. Water is white. This means this is a T2 weighted pelvic MRI. And why I am saying female? Because I can see this particular structure sitting on the uterus. Can you tell me what is this? That is your sitting on the urinary bladder. On the top of it, that is your uterus. That is your uterus. And on the side of it, you can see the ovaries with multiple follicles. Okay, you can see the ovaries and uterus. Now, important thing here is, if I now show you the uterus in sagittal plane. On the sagittal plane, if this is your urinary bladder, in MRI, the uterus is sitting like this. Anteverted. Can you see the uterus sitting on the bladder like this? So this is your uterus on sagittal MRI, and the first image was a coronal image. Okay, first image was coronal, second is sagittal. Can you think of some indications? Can you now go back to your knowledge, clinical knowledge or basic sciences knowledge, some indications of gynecological MRI? I will tell you 4 or 5 questions, very important. First is, if you are suspecting adenomyosis, what is the investigation of choice? Okay, adenomyosis means that the endometrial glands are invading the myometrium. So adenomyosis is diagnosed on MRI if the junctional zone, junction between endometrium and myometrium, is thickened more than 12 millimeter. If the junctional zone on MRI is thickened more than 12 millimeter, you will call it adenomyosis. I will show you what is junctional zone. Please see and understand. Spend a moment with me. एक बार थोड़ा सा टाइम बिताते हैं. ये एंडोमेट्रियम है, ये मायोमेट्रियम है. ओके, इनके बीच में एक डार्क सा जोन दिखेगा. बिटवीन देम यू विल सी दिस डार्क जोन, दिस वेयर आई एम राइटिंग J. That is your junctional zone. Junctional zone thickening more than 12 millimeter would be adenomyosis. जो इमेज है ये नॉर्मल है. I am just telling you what are the indications of doing a MRI in pelvis in female. Second is deep-seated endometriosis. Endometriosis को देखने में भी MRI का रोल है. MRI can find out if there is any endometriosis, or it can even diagnose a chocolate cyst. It can diagnose a chocolate cyst, and it can find deep-seated rectosigmoid endometriosis. I will explain to you. Sometimes what happens is, if this is your uterus, sometimes the endometriosis might be hidden here between the rectum and in the area of pouch of Douglas between the rectum and the uterus. Sometimes the endometriosis is hidden here. Okay, and this kind of endometriosis, if I see endometriosis hidden here like this, it is called as mushroom cap sign. So deep endometriosis in the rectouterine pouch, in the pouch of Douglas area, can be seen on MRI. This is one of the indications of doing a MRI to find out deep-seated endometriosis. If you find it in the rectouterine pouch, you will see appearance called as mushroom cap sign. MRI is also indicated to make a diagnosis of Mullerian abnormalities. But remember, it is considered the gold standard for Mullerian abnormalities. Investigation of choice is 3D ultrasound. MRI is also indicated to look for parametrial invasion in gynecological malignancies like CA cervix. Okay, I am repeating all of this again. There are few gynecological indications of MRI. Gynae में MRI कहाँ पे करने का है? पहले याद कर लेते हैं adenomyosis. So in adenomyosis, the junctional area, the dark junctional area between the endometrium and the myometrium is thickened. That is adenomyosis. It can look for endometriosis. It can help you diagnose chocolate cyst. It can help you find rectouterine endometriosis, which looks like a mushroom cap. It is the gold standard for Mullerian abnormalities. However, investigation of choice for Mullerian abnormality is a 3D ultrasound. MRI can also help you to do the staging of CA cervix by finding out Mullerian abnormalities. Clear? Everybody understands? So mushroom cap sign is this that I have drawn here. Suppose you have endometriosis between the uterus and the rectum. It takes a shape like this. It takes the shape that I have drawn here. This is what is called as the mushroom cap appearance. This is what is called as the mushroom cap appearance. What is mushroom cap appearance? Deep-seated endometriosis in the rectouterine area. All this is possible. So what happens is, you have to keep your mind open that in pelvic imaging, in pelvis, MRI is superior to CT, including female pelvis, and these are the indications. Even in conditions like fistula in ano. Today the investigation of choice is MRI. Today the investigation of choice for fistula in ano is also MRI. And just like I just now mentioned, I think some bacha Abhishek missed it, that if you have CA cervix and the tumor invades into parametrium, that is also diagnosed on MRI today. Parametrial invasion of CA cervix. Today, if you have a perianal fistula, the treatment and the further course depends on the relationship with sphincters. Is the fistula located between the internal and external sphincter? Or is it above the levator? Is it cutting the sphincter? So this entire anatomy of fistula in ano is visible on MRI. So if you have a patient with fistula in ano, go for MRI. Prostatic abnormality, prostate evaluation, go for MRI. I will show you how prostate looks like on MRI. If we take a section through the lower part of the bladder, this is your urinary bladder. Fistula in ano, somic ano, anus, okay, and this is your rectum, okay. So I hope you can see the bladder, the lower part of bladder, we are cutting through it, and just below and behind the bladder you have your prostate. So you can see this particular structure that I am trying to outline here is your prostate. Okay, beta. This is your obturator internus. This sling-like muscle that you see here is your levator ani. In between the levator and the ischium is your ischiorectal fossa. Okay, because the bladder is appearing white, aksanaya, so the bladder is full of urine which is white, water is white. This must be a T2 weighted image. This is a T2 weighted image through the lower part of bladder, and I will just label the structures again for you. 1 is bladder, 2 is prostate, 3 is rectum, 4 is obturator internus, 5 is levator ani, and 6 is ischiorectal fossa. Okay, this is the axial image through the lower part of the bladder where the prostate is below and behind the bladder. So we can see it. And if you spend one extra moment with me, you can see the prostate has two zones. Transitional zone, peripheral zone. Can you see? The center part is more darker than the peripheral part. So MRI can even show us the zonal differentiation. This is the transitional zone. This is the peripheral zone, which is more bright. And I'm sure you know by now that the cancer in the prostate is more common in the peripheral zone as compared to the central zone. So they might ask you in the exam, for prostate, what is preferred? MRI is preferred. MRI is preferred. Okay. And even in prostate, if you see a nodule today, we calculate on MRI of the prostate a score called as Pirard score. So Pirards is the nomenclature that is used in prostate on MRI, using the appearance on T2 weighted image, diffusion weighted image, dynamic contrast enhanced image. Just one line to remember, everything else you can forget. Everything else you can forget, that even for prostate MRI is used. Pirard's nomenclature of prostate is based on MRI of prostate. If they go deeper than this, they will ask you MRI में कौन सी 3 investigation पे Pirards को देखते हैं. So you look at these 3 images: T2 weighted image, diffusion weighted image, dynamic contrast enhanced image. T2 weighted image, diffusion weighted image, dynamic contrast enhanced image. Okay. So even for prostatic imaging, fistula and NO, MRI is the king. MRI can even show us the zonal architecture of uterus, zonal architecture of prostate. Okay. And one was bladder, definitely. Now, can we use dye or contrast material in MRI? Answer is yes. But it is different from CT. In CT, we were using radiation, so we were using iodinated contrast. In MRI, the contrast material used is gadolinium. Dye used in MRI is gadolinium. Okay, I think some bacha has missed a point, so let us zoom the image once more. Okay, I'm labeling the image once more beta for the children who could not follow. Bladder, prostate, rectum, obturator internus, levator ani, ischiorectal fossa. Clear bache? Vijay Lakshmi, now are you clear? Okay. So question is, what is the contrast material used in MRI? We use gadolinium. Why? Because gadolinium is a paramagnetic substance which causes shortening of the T1 time of the tissue where it goes. Important question. In CT scan, we were using iodinated contrast because iodine is radio-opaque. In MRI, we are using gadolinium because gadolinium is a paramagnetic substance, causes shortening of the T1 time. That means after giving contrast, after giving gadolinium, we obtain a T1 weighted image. Okay. We will सत्य प्रभा बेटा देखो, अगर किसी को Mullerian abnormality है, we were doing ultrasound with a special technology called as 3D ultrasound, which is able to show us 3-dimensional images. Earlier we used to say that ultrasound pe we cannot find all the Mullerian abnormalities properly, we cannot differentiate between bicornuate and septate. But with advent of 3D ultrasound, it is changed now. Now the investigation of choice for Mullerian abnormality is 3D ultrasound. Gold standard is MRI. It is changed from the past. Earlier we used to say MRI is IOC. But now ultrasound has become so good that it has 3D capabilities. Okay, beta? Now, After giving gadolinium, we obtain a T1 weighted image of the patient. Why? Because gadolinium causes T1 shortening. Gadolinium causes T1 shortening. Anything we need to know about gadolinium? Only 2-3 things. Gadolinium is contraindicated in pregnancy because it crosses the placental barrier. Because it crosses the placental barrier. I am again repeating, beta, socho mere saath. If a drug crosses the placental barrier, it can cause teratogenic effect. It can go into the fetus. So whenever in pregnancy we do MRI, we do plain MRI. Pregnancy में MRI plain होता है, उसमें dye नहीं देते, because gadolinium is contraindicated in pregnancy. Number 2, gadolinium is contraindicated in CRF or in patients with estimated GFR less than 30 ml per minute, because if you give gadolinium in these patients with renal insufficiency, it accumulates in the body and causes multi-system fibrosis, which is called as nephrogenic systemic fibrosis. Nephrogenic systemic fibrosis. I am again repeating. Gadolinium is a safe dye used in MRI. It predominantly acts on T1 weighted images. So post-contrast images are T1 weighted images. It is contraindicated in pregnancy. It is contraindicated in CRF. In pregnancy, it is contraindicated because it crosses the placental barrier. In CRF, it is contraindicated because it causes multi-organ system fibrosis called as nephrogenic systemic fibrosis. Okay? So see, देखो, Sarvani, एक बार समझना बेटा, Sarvani. In a plain MRI, pathology is better picked up on T2 weighted image. But on contrast imaging, when I give IV contrast, the disease will be seen on T1 weighted image because gadolinium is visible on T1 weighted image. I will explain and show it to you with multiple examples, don't worry. First of all, I will now spend a moment, okay beta, very, very important part of the class. Very, very important part of the class where we will shift focus from normal to abnormal. So you will enjoy it. You will feel like Sherlock Holmes. But I want you to tell me, listen to me beta. Suppose these are your brain capillary endothelial cells. Suppose these are your brain capillary endothelial cells. Okay, they are tightly bound to each other. And suppose this is your basement membrane surrounding them. And suppose these are your astrocytes and these are the astrocyte foot processes. Tell me, what am I trying to build up? What am I trying to build up? This is your blood-brain barrier. Anytime we give intravenous gadolinium, anytime we give to the patient IV gadolinium, it cannot go into the brain. Why? Because gadolinium, tell me, cannot cross the blood-brain barrier. It cannot cross the blood-brain barrier. Okay, bache? It cannot cross the blood-brain barrier. But try and tell me, suppose you have inflammation. Or suppose you have a neoplasm. What will happen? In inflammation, your capillaries become leaky. In neoplasms, the blood vessels are neovascularization happens. A lot of new vessels are found which may have leaky blood-brain barrier. Now, what happens here is, please see an answer. What happens here is, in inflammation, this capillary, the blood-brain barrier will become leaky. So the dye which was there in your capillaries, starts to go into the tissue. So this is the basic principle of contrast enhancement. That means if I give intravenous contrast, listen to me everybody, listen to me. If I give IV contrast, if a part of the brain is taking up the dye, that means it is inflamed, or if it is thick area of inflammation, solid area, it could be, or we are looking at a tumor. So it is important to understand how to use contrast enhancement. To make sure you understand, I will give you an image to diagnose. So all of you brilliant students in the class, and I'm telling you, you're the most intelligent students I've ever taught in the class. Can you look at an image together with me? Let us do it together. Look at the image and tell me what body part is this. Tell me, anybody. This is your brain. This is your brain. MRI, because the bone is dark and the CSF is dark. The CSF is dark, but not only the CSF is dark, the white matter is also dark. That means we are looking at flare MRI. This is a flare axial MRI of the brain. Now tell me, normal, abnormal? Normal, abnormal? Don't run to diagnosis, beta. Don't run to diagnosis. Normal, abnormal. What is the problem? Multiple areas of hyperintensity in the white matter. Multiple asymmetric white matter abnormality. है ना, asymmetric है, white matter में abnormality दिख रही है. Okay, so let's think of it now. अब white matter में अभी मैंने सिखाया था पहले, I taught you white matter में myelin है. So whenever we see asymmetric white matter abnormalities in somebody with neurological illness, one of the neurological illness comes to my mind, which is demyelinating illness of the central nervous system, which is called as multiple sclerosis. So I have a doubt, is this multiple sclerosis? I have a doubt, am I looking at multiple sclerosis? So how will we confirm? अभी white matter में problem है, हो सकता है multiple sclerosis हो, पता कैसे, confirm कैसे करेंगे? How do we confirm this is multiple sclerosis? To confirm it, I need to go into the pathophysiology of the disease. Suppose I look at a microscopic section in a patient with multiple sclerosis. Multiple sclerosis is earlier believed to be an idiopathic immune demyelinating disease. Now it is believed to be triggered by Epstein-Barr virus infection. I'm sure you might be reading all this. It is proven to be associated with Epstein-Barr virus prior infection. So if this is a vein, if this is your vein, in multiple sclerosis, because it's a chronic inflammation happening causing demyelination, you can see the chronic mononuclear infiltrate surrounding the veins. Can you see these lymphocytes surrounding the veins? Yes. So what is happening in MS? You have perivenular lymphocytic infiltrates. Okay. Now, important thing for all of you is to listen to me, that suppose this is your lateral ventricle. From the surface of your lateral ventricle, we have subependymal veins. From the surface of the lateral ventricle, you have subependymal veins which are oriented perpendicular to the ventricle. So in our body, in our brain, from the surface of the lateral ventricle, you have veins going like this. And what is happening in MS? You have perivenular predominance of the inflammation. So where will you see demyelination? Demyelination is seen surrounding the veins. Primarily surrounding the veins. And veins are perpendicular to the ventricle. So if I do a sagittal section, everybody listen to me. If I do a sagittal section, you will see finger-like areas of demyelination perpendicular to the ventricle. You will see finger-like areas of abnormality oriented perpendicular to the lateral ventricle. Can anybody tell me the name of the sign that I am just describing to you? This is called as Dawson's finger. Are you clear? These are called as, yes, Dr. Jessica is correctly answered, they're called Dawson's fingers. So to confirm that we are looking at MS, I need to look at a sagittal image. I cannot confirm on an axial image. I want to see the sagittal image. And can you see these finger-like areas of demyelination oriented like fingers, perpendicular to the lateral ventricle, called as Dawson's finger? But this is not enough. Multiple sclerosis is a relapsing remitting illness. Multiple sclerosis is a relapsing remitting illness. So I should see some evidence of old disease and new disease occurring in the image. I will show it to you. I want you to spend a moment with me. I am repeating with, for Hari Shankaran I am repeating again. देखो, multiple sclerosis में white matter में abnormality है. But this abnormality pathologically is seen to be around the veins. And veins are oriented perpendicular to the lateral ventricle. So demyelination also is perpendicular to the lateral ventricle, which is called as Dawson's fingers. Okay, are you clear? Now this is, we don't know why it is happening, but this is given in your pathology book also, that multiple sclerosis pathological findings are concentrated around the veins. We don't know why it happens, but this is around the veins. And that is the reason for, that is the why behind Dawson's fingers being perpendicular to the lateral ventricle. Now I want you to see this image, everybody. Okay, I am going to show you an image. Everybody look at this image with me. Okay, I will label it beta. This is a T2 weighted image. This is a contrast enhanced MRI. This is a spinal MRI. Okay. I am going very, very slow. Very, very slow. It is a very important concept. Can you see there are multiple white matter abnormalities? Achha, SAG means sagittal. SAG means sagittal cut beta. Can you see, all of you beta, can you see these are multiple white matter abnormalities on T2 weighted image? But when we do a contrast image in the same patient, only this lesion and this lesion is showing the contrast enhancement. Okay, can you tell me why? अब बच्चे सोच के बताना है. मैं हिंदी में इंग्लिश में दोनों में बोलूंगा, ध्यान से सुनना है. देखो, दोबारा से देखो. Apurva, please see. Normal myelin should be dark on T2 weighted image. Remember I told you normal myelin should be dark on T2 weighted image. So the white area is abnormal. On T2 weighted image, you have multifocal areas of abnormality in white matter. So बहुत 4 या 5 जगह दिख रही है जहां problem है. But when I see the contrast image, only 1 or 2 of them are picking up the contrast. Others are not enhancing. अब एक वर्ड सुनो, enhancement. Contrast अगर कोई बीमारी अपटेक कर रही है, we will call it enhancement. If any disease is taking up contrast, we are saying enhancement. Now tell me, why are the other lesions not enhancing? That means only 2 of these are actively inflamed where the capillary blood-brain barrier is defective. Others are old lesions. बीमारी तो है वो पुराने, ये active inflammation है. That means the disease is disseminated in time. बीमारी समय के चक्र में फैली हुई है, कुछ पुरानी है कुछ नहीं है. I'm repeating in English also that the disease is disseminated in time. That means that although there are multifocal lesions on T2 weighted MRI, only a few of them are enhancing, others are not enhancing. That means they are old lesions. That means there are old lesions also, new lesions also. मतलब बीमारी पहले भी थी. It is a old disease which has now relapsed. It is a relapsing remitting disease. Clear? इसको कहते हैं dissemination in time. Now I want you to look at the spinal cord of this patient. And in the spinal cord we can see there is one small focal lesion in the cord. So my question to you is the disease limited to brain or is it disseminated to other parts in the central nervous system? Yes, it is disseminated to spinal cord also. That means it is a multi-compartmental disease. It is called as dissemination in space. Clear? So इसको कहते हैं dissemination in space and time. This is how MRI helps you to diagnose dissemination in space and time. Okay. Now I will give you one question to solve. I am going to give you a clinical vignette to solve. A HIV positive patient, an HIV positive patient has CD4 count less than 200, has some neurological complaint. MRI shows asymmetrical white matter abnormality, non-enhancing, no mass effect. Okay. So let me repeat for Dr. Vishaka. So Vishaka, what I'm trying to repeat here is कि स्पाइन में क्या था, मल्टी कंपार्टमेंट दिखा रहे हैं ना. देखो बच्चे, मैं हिंदी में भी रिपीट कर रहा हूं आपके लिए दोबारा कि इफ देयर इज अ डिजीज विच इज इन्वॉल्विंग बोथ द ब्रेन एंड द स्पाइनल कॉर्ड, इट मींस इट इज मल्टी कंपार्टमेंटल. मतलब ये कोई लोकल बीमारी नहीं है ना, कुछ सिस्टमिक हो रहा है जो यहां पे भी है, कॉर्ड में भी है, मल्टी कंपार्टमेंट है. सो वी आर सेइंग डिसेमिनेटेड इन स्पेस. That is a mark of a immune mediated disorder. Now anybody can answer my question. A HIV positive patient has CD4 count less than 200. On MRI there is asymmetrical white matter abnormality which is not enhancing, no mass effect. Okay, this is not toxoplasma. Can anybody tell me why this is not toxoplasma? कई बच्चे कह रहे हैं toxoplasma आंसर है. बताओ टॉक्सोप्लाज्मोसिस क्यों नहीं है? Why not? Because toxoplasma is an infection. It will cause inflammation. If there is inflammation, there will be breakdown of blood-brain barrier. The lesion should take up dye. It cannot be non-enhancing. Non-enhancing समझ, dye का अपटेक ही नहीं हो रहा, तो ऐसे कैसे हो सकता है? So now try and understand. HIV is known to be associated with a viral infection called as JC virus. John Cunningham virus or JC virus. This JC virus is known to damage the oligodendrocyte. It is known to affect the oligodendrocytes. Now, what is the function of oligodendrocytes? What is the function of oligodendrocytes? Oligodendrocytes in our central nervous system are responsible for myelination. Just like in your peripheral nerves, you have Schwann cells which are responsible for myelination. In central nervous system, you have oligodendrocytes responsible for myelination. अगर oligodendrocyte बीमार होगा, if there is a disease in the oligodendrocyte, what will happen? In one focal area of the brain, what will happen? There will be problem in the myelination. So वहां myelination नहीं होगा. So that part of the brain, the white matter will be abnormal. Then what will happen? As the disease progresses, more oligodendrocytes will be involved. If more oligodendrocytes will be involved, there will be multiple areas of white matter abnormality. So let us call this disease as progressive multifocal leukoencephalopathy, PMLE. ओके, मास इफेक्ट का मतलब क्या धैर्य? मास इफेक्ट का मतलब है कि अगर कोई ट्यूमर होता ना, ये ट्यूमर, एचआईवी में ट्यूमर भी तो हो सकता है, एचआईवी में लिम्फोमा भी हो सकता है मरीज को. ओके, ब्रेन में लिम्फोमा हो सकता है एचआईवी में, यू कैन रीड धारिया लेटर ऑन. तो इफ इट इज अ ट्यूमर, इट विल कंप्रेस द सराउंडिंग स्ट्रक्चर, इट विल हैव सम मास इफेक्ट. इट्स अ ट्यूमर, बट दिस इज नॉट अ ट्यूमर. दिस इज अ प्रॉब्लम इन माइलिनेशन ड्यू टू वायरल इन्फेक्शन, बिकॉज वी नो JC virus is causing damage to your oligodendrocytes. It is causing damage to your oligodendrocytes. That is the idea. It is not inflammatory destruction of myelin. Multiple sclerosis is triggering an inflammation which is causing demyelination. क्योंकि यहाँ inflammation नहीं है तो enhancement नहीं है. And association with HIV. Are you able to solve the clinical vignette now? HIV positive patient with asymmetric white matter abnormality which is non-enhancing, no mass effect. Think of PMLE. Anybody? PMLE is also associated with one drug. Which drug is associated with PMLE? It is associated with JC virus, HIV, but one drug. Can you name one drug which is associated with PMLE? Anybody can answer this question in the chat box. Natalizumab. You can read it later on in your pharma class also. Natalizumab is also associated with PMLE. So they can make a question. But remember, on MRI, the key words of PMLE are asymmetric white matter abnormality, not taking up the dye, no mass effect, history saying HIV positive, or they will say natalizumab therapy. Okay, very good beta. Now, I will give you one more question to solve. Let's see how many of you are able to solve my question. Okay, I will give you a question. A child comes to you Everybody try to answer my question, beta. A child comes to you with developmental delay. MRI shows symmetric white matter abnormality. What should you suspect? The ventricles are normal. See, I see some bachas are still getting confused. Why non-enhancing? Why not toxoplasma? Try to understand, beta. Dekho, when does a brain parenchymal tissue will enhance? It will enhance if it is having deficiency in blood-brain barrier, or it is a tumor, or if it is a inflamed tissue. If it was toxoplasma, it will cause surrounding inflammation. It will be seen like a ring-enhancing lesion. While PML is not inflammatory destruction of myelin, it is a problem in oligodendrocyte caused by viral inclusions in the oligodendrocyte. So it does not have local inflammation. Okay. So if you see a child, a pediatric patient with developmental delay, symmetrical problem in the white matter, ventricle normal, think of some problem in the myelination which can be described as leukodystrophy. I will explain it to you. Okay, I think I can explain it to you. Try to understand. Whenever you see a question like this, first thing you should see is the head size large? Does the child have large head? Because there are only two important leukodystrophies where the child will have developmental delay. The lateral ventricles are normal, but the head is still large. Can you name them? Name two leukodystrophies associated with large head. Anybody? Now this is not cerebral palsy, beta. Cerebral palsy में ऐसा नहीं होगा. Cerebral palsy में आपको white matter में damage मिलेगा और ventricle साथ में ventricle will be dilated. Now tell me anybody, large head. Which causes of leukodystrophy will have large head? Answer: Alexander's disease and Canavan's disease. Very important question. Alexander and Canavan's are two leukodystrophies which will have large head. How to differentiate between them? Alexander's disease is frontal predominant. It is a GFAP gene mutation. On microscopy shows a lot of fibers. Which fibers? Rosenthal fibers scattered in the brain. Hence called as fibrinoid leukodystrophy. Canavan's disease will involve the entire brain diffusely. There is no favorite area. Entire white matter will be involved. On MR spectroscopy, you will see elevated N-acetyl aspartate level because it is a amino acid pathy. It is a disease of the amino acid. It is aspartoacylase deficiency. Aspartoacylase deficiency. Okay. Now, before I go on, let's look at the image and try to answer. एक बार इस image को देखना बेटा. I am removing myself. Just see the image. Can you see the white matter throughout the brain is very, very bright. So there is a diffuse involvement of the white matter. It is all white. एकदम बिल्कुल white हो गया है. And there is a MR spectroscopic image showing you a large tower-like peak of N-acetyl aspartate. What do you think we are dealing with? What do you think we are dealing with? We are dealing with Canavan's disease. This is an image showing you Canavan's disease. So what will they write in the exam? Clinical vignette, they will say patient has large head, developmental delay, okay, ventricular system is not dilated, ventricles are normal. There is symmetric involvement of white matter telling you that something is wrong which is involving the entire of the white matter. Okay, very good. Now look at the second example. Now look at this image, and I am sure you can pick up that this area is very, very white. Okay. So the area which is abnormal is, can you see here, the cortex is normal. It is the white matter which is symmetrically very, very white, but it is in the front of the brain. So frontal lobe involvement, anybody, frontal lobe involvement, large head, genetic problem, glial fibrillary protein, you might have read of GFAP gene mutation. On microscopy, it has rosenthal fibers scattered in the brain parenchyma. Think of Alexander's disease, also called as fibrinoid leukodystrophy. How to identify? दोनों में large head है, Alexander's में frontal predominance है, Alexander's is frontal predominant, while Canavan's has no such predominance with elevated N-acetyl aspartate levels. Clear? Easy to understand? Okay. And a previous INI-CT question. Name 2 leukodystrophies where you have large head. Alexander's, Canavan's. Alexander's, Canavan's. Alexander's, Canavan's. Now, let's go make it more tough now. We'll go deep into it. Okay. We will go deep into it. Now, when I go deeper into it, the question is, can you name in our brain, just below the cortex, just below the gray matter, you have subcortical U fibers. Okay, I will again repeat. In our brain, just below the cortex, we have subcortical U fibers. I want everybody to listen to me. These subcortical U fibers are short association fibers which are known to have very slow myelin turnover. They are known to have that यहाँ myelin एक बार चिपक गया ना तो चिपक जाता है. Myelin turnover नहीं होता इसमें. Normally in our body what happens, myelin is laid down, then removed, then laid down. In this area the myelin turnover is very, very slow. It is not there. So suppose you have any disease which is affecting the myelin turnover. For example, you have lysosomal diseases or peroxisomal diseases which damage the white matter of your brain by accelerating the myelin turnover. If it is a lysosomal disorder or peroxisomal disorder, subcortical U fibers will not be involved. Okay, I am again repeating, it is slightly tough. See, देखो, just below the cortex of your brain, we have U-shaped association fibers which are called as subcortical U fibers. These fibers have a very, very slow myelin turnover. So diseases which are damaging the myelin by accelerating myelin turnover like lysosomal processes or peroxisomal processes, subcortical U fibers will be spared. I will give you examples. Listen to me. Name a lysosomal disorder. Name a lysosomal disorder which affects the, listen to me, which affects the enzyme aryl sulfatase A deficiency. Can you name it? Aryl sulfatase A deficiency is called as metachromatic leukodystrophy. Subcortical U fibers will be spared because it is a lysosomal process. It's a lysosomal process. Okay. Now, in metachromatic leukodystrophy, the interesting thing is, if this is your myelin, it has perivascular sparing. That means some area surrounding the vessel is not affected by the problem, by the disease, giving rise to a tigroid pattern on MRI, tiger skin like pattern on MRI, metachromatic leukodystrophy. Second lysosomal disorder that I want to cover today is due to beta galactosidase deficiency. Anybody knows the name? Krabbe's disease. Krabbe's disease. Krabbe's disease is also called as the globoid cell leukodystrophy due to beta galactosidase deficiency. It also causes damage to the white matter, but unique thing is thalamus involvement. If there is a white matter abnormality causing thalamic damage, think of Krabbe's disease. And in peroxisomal disorders, we need to remember, X-linked leukodystrophy, X-linked adrenoleukodystrophy, a disease affecting the adrenal and the brain white matter caused by peroxisomal disorder. Anybody? X-linked adrenoleukodystrophy. Anybody is aware of it? Tell me. Seen in boys. Seen in boys because it is X-linked. Typically involves the posterior part of the brain, parieto-occipital part of the brain. It involves the posterior part of the brain. Now what we will do is we will look at the image and do it again. Okay. Everybody listen to me. एक बार दोबारा देखो. MRI में there is abnormality symmetric abnormality in the white matter in the frontal lobes. Alexander's disease. अब ये वाला देखो. Where is the abnormality? Symmetrically present. Ventricles are normal. Symmetrical white matter abnormality. Where? Posterior part of the brain. What do you think we should mark the answer as? Adrenoleukodystrophy. Adrenoleukodystrophy will affect the posterior part of the brain. It will affect the posterior part of the brain like this, symmetrically. White matter abnormality symmetrically. Okay. And in Krabbe's, I told you already, thalamus will be involved. That is important. Some bacha is asking, very important. Again, see one more example of a disease. Same patient, two images are given. One image is a FLAIR image. One is a T2 weighted image. Okay. एक तो FLAIR image है और एक T2 weighted image है. Okay. So what do you see in the FLAIR image? Symmetric white matter abnormality. Symmetric white matter abnormality pointing towards leukodystrophy. When I look at the T2 weighted image of the same patient, in the white matter there is abnormality, but there is some areas which are causing this striped appearance in between. Some areas which are normal. What is this cause? What is this called as? This is called as tigroid pattern. Tigroid pattern is seen in? Any one of you can answer? Metachromatic leukodystrophy. Metachromatic leukodystrophy. So I am again repeating. X-linked adrenoleukodystrophy is a peroxisomal disorder in which subcortical U fibers will be spared. Patient will be typically male because it is X-linked, and the disease will be involving the posterior part of the brain. So adrenoleukodystrophy जो होता है, it is progressing from behind forward. Alexander's disease has a spread from it is causing damage from front backwards. So Alexander's disease involves the frontal lobe more. Adrenoleukodystrophy involves the parietal and the occipital lobe more. Okay. So we don't have a slide on Krabbe's disease. Only the word you need to remember is thalamic involvement. Krabbe's disease is also called as globoid cell leukodystrophy. Thalamic involvement, if written with a leukodystrophy, go for Krabbe's disease as the answer. Okay. Now here the FLAIR is only showing a symmetric white matter abnormality. Dekho, inflammatory, if it is an inflammatory disease, the problem might be asymmetric. But this is some inborn error of metabolism. So we are seeing symmetric abnormality in the white matter. Everybody follows? Okay. Now let's repeat and revise. What I have shown you so far is, I have shown you problems in the white matter. I have shown you multiple sclerosis. I have talked about PML, I have talked about HIV and PML, I have talked about some leukodystrophies which can have large head, some which will have tigroid appearance, and I've given you some clues in the question which you need to remember. Okay, now any one of you can look at this contrast enhanced MRI and describe it for me. Okay, Bhargav देखो, T1 shortening का मतलब है कि if I give IV contrast, the area which will pick up the dye will look more white, just like you see in this particular image. Can you see here? This is a contrast MRI. So one ring-like area is taking up the dye. This is called as, anybody, ring enhancing lesion. इसको कहते हैं ring enhancing lesion. What could be the causes of ring enhancing lesion? The causes can be NCC. Happy? One of you was repeatedly saying, sir, NCC दिखाओ. NCC. Neurocysticercosis, tuberculoma, toxoplasmosis, brain abscess, and metastasis. What are the causes of ring enhancing lesion? 5 classic causes of ring enhancing lesion are, 4 of them are infections, 1 is metastasis. Infections are neurocysticercosis, tuberculosis, toxoplasma, brain abscess, metastasis. Okay. And you might have seen in one of the integrated MCQ rounds, I think me and Dr. Achin has already discussed this topic at length in the integrated MCQ rounds. If you are not attending it, you can go to the short courses. You have a free access to weekly clinical grand rounds and weekly integrated rounds. It is a good course. You should see it, where 2 teachers are discussing our concept. So we have discussed the ring enhancing lesion at that time, but I will repeat. Try to understand. Okay, just focus on the screen for 1 second. Suppose you have an infection in the brain, some infection in the brain. What will happen? It will cause surrounding inflammation. It will cause surrounding inflammation. If you have inflammation, what will happen to the blood-brain barrier? Beta, ek baar batao. If you have inflammation, what will happen to the blood-brain barrier? Blood-brain barrier will become leaky, and there will be ring-like enhancement around the disease, which is called as ring enhancing lesion. So whenever I see this smooth ring enhancing lesion in the brain, first thing that comes to my mind is infection. Infection could be neurocysticercosis, tuberculosis, toxoplasma, brain abscess. But I also know that even metastatic lesions can mimic ring enhancing lesions. So I'm keeping that in the DD. Okay. I will give you one example of NCC. Neurocysticercosis, when it goes to the brain, initially it is viable. Neurocysticercosis, when it goes into the brain, initially it is viable. So it looks, it has a cyst and a scolex. It is alive. What is the name of the cyst? What is the name of the stage? Now, whenever I will show you any contrast enhanced CT or MRI, it will be written in the question that this is contrast image, because one image you cannot tell, you need to write it in the question itself. This stage is called as vesicular stage. Okay. So in the vesicular stage, you will see cyst and scolex. It is a viable stage. So if it is viable stage, what will happen to the cell membrane? If it is viable stage, the cell membrane of the parasite will be intact. If the cell membrane of the parasite is intact, can our immune system see it? No, we cannot see it, because cell membrane of the parasite is protecting it against our immune system. So our immune system is not attacking it. So that means there will be no inflammation. That means there will be no inflammation. Anybody, if there is no inflammation, will there be ring enhancement? No ring enhancement, no edema. Are you clear? Vesicular stage of NCC is viable stage. It will show a cyst-like lesion with scolex, with no inflammation, no enhancement, no edema. I will show it to you. I will show it to you. Please see this image. This is a previous NEET PG image from the class directly. See it here. Everybody, what are you able to see? Can you see this CSF or water-filled space, cystic spaces which have a scolex inside, tapeworm which have a scolex? These are vesicular stage of cysticercosis. Can you see it here? Scolex inside. Cyst with scolex appearance. What is your diagnosis? NCC. What is your diagnosis? NCC. Okay, everybody gets it? Okay, now let's understand further. So this is the viable stage. But when the parasite will start to die, when the parasite will start to degenerate, what will happen to the parasite? When the parasite will start to die, the fluid in the cyst will become more granular, more like a colloid, and the membrane will rupture. In the degenerating stage, the water inside the cysticercosis will become more like a colloid. It will become more thick, that is called as the colloidal stage, and the membrane will start having perforations. If the parasitic membrane ruptures, the protein from the parasite will come out, and the protein is immunogenic. Because the protein is immunogenic, what will happen? Our immune system will be able to see it. And immediately what will our immunity do? What will our inflammation do? Inflammation बोलेगा चारों तरफ से इसको घेर लो. So our inflammation will try to surround the enemy from all sides. That is why we have a ring-like lesion, because we have to surround it from all sides. So you will have a ring-like inflammation surrounding it. If I give IV contrast to the patient, the blood-brain barrier will be leaky and you will start to see a ring-enhancing lesion. So colloidal stage you will see ring-enhancing lesion. And the capillaries are leaking, so the fluid will leak into the surrounding parenchyma. So what will you see in colloidal stage? You will see ring-enhancing lesion. You will find edema around it and the patient will be symptomatic. Are you able to understand this? So then the parasite is degenerating. That is when the symptoms are going to happen. Are you able to understand the reason why? Because जब वो जिंदा है, उसकी membrane intact है. An intact membrane is not causing inflammation. Inflammation happens when the membrane breaks and the protein comes out. Then what will happen? Ultimately the parasite will die. When the parasite is dead, we have to give respect to the dead. Although NCC is our enemy, but when it is dead, to give respect to the dead, we will put some calcium on it and it will become a nodule of calcium. So when it dies, it becomes calcium nodule with again there will be no enhancement, no uptake of dye, no edema. Okay. Okay, are you clear beta or not? So are you able to understand that the key word is, I am again repeating for all of you, that neurocysticercosis in the vesicular stage is cyst with scolex appearance. In degenerating stage it becomes ring enhancing with edema. In the dead stage it becomes a nodule of calcium with no enhancement, no edema. Everybody able to follow my point? Okay, colloidal matlab degenerating. Colloidal matlab degenerating, calcified matlab dead. Clear? Okay. I will just tell you one more line here. It is not necessary that cysticercus will go to the brain. It can also go to your muscles. So when the cysticercus goes to your muscles, it is called as myocysticercosis. And muscle fibers are like this. Muscle fibers are shaped like a spindle. Muscle fibers are shaped like a spindle. So if you have a calcified parasite inside them, it will look like this. What is the appearance? Like rice grains. Can you see in the muscles multiple calcified NCC looking like multiple calcified cysticercosis looking like rice grains. This is called as rice grain appearance. Why you have a rice grain appearance, anybody? Because when it is in the muscles, it takes the shape of the muscle. Muscle fibers are like a spindle, so the cysticercus becomes elongated. When it becomes calcified, it becomes like a rice grain. Rice grain calcification in the muscle fibers, cysticercosis. Okay. Now let us try to make it more deeper for you. And I hope now you are enjoying it, because in the beginning of my class I was telling you how MRI is, what is the anatomy. Now I am showing you how the disease process is. I want you to look here, this area. I want you to look at this. Enhancement beta, Henry Patel. Enhancement matlab contrast diya hua hai. Enhancement means uptake of dye. So whenever I use the word enhancement, it means we are looking at a contrast enhanced MRI. Suppose I am saying this is a contrast enhanced MRI. You are able to see these ring enhancing lesions. Any one of you can look at this image and tell me what is so peculiar about this ring enhancing lesion. These ring lesions are, tell me, are like a bunch. They are joined with each other like matting that happens in tuberculosis. These are conglomerate ring enhancing lesion. We will call them conglomerate ring enhancing lesion. That means we are dealing with a disease process which is coalescing, which is known to happen in tubercular lesions, tuberculoma. Conglomerate ring enhancing lesions, think of tuberculoma. My question is, if you do MR spectroscopy in this patient, if you do MR spectroscopy in this patient, what will you find? You will find an abnormally high lipid peak. Did I tell you this already? That lipid peak in a brain lesion is a sign of presence of necrosis. Neurocysticercosis is a cystic lesion. Tuberculosis, the central part is necrotic. So where will you see lipid peak? In tuberculomas, not in NCC. Tuberculomas will be conglomerate. NCC will be discrete, single. NCC can have different appearances of different stages. Remember, it could be calcified, it could be ring enhancing, could have scolex. While tubercular lesions will be conglomerate with lipid peak on MR spectroscopy. Okay, very good. Now, one more question for you. I am removing myself. It's a very typical question. Let's see how many of you are able to answer this. I have not talked about this. I just want you to, spend a moment with me. This is your midbrain. Contrast enhanced MRI images are there. Surrounding the midbrain, in your basal cisterns, you can see there is irregular dye uptake. Can you see thick dye uptake in the interpeduncular fossa, around the midbrain? There is uptake of dye. Okay. Okay. So before I answer this question, let me answer one question by Sangram. Sangram, देखो cysticercosis जब जिंदा है, when the cysticercosis in the brain is alive, then you will have no enhancement. When it is dying, जब वो मर रहा है, then there will be enhancement. When it is dead, again there will be no enhancement. Okay? Anybody now wants to answer this question? What do you see in this image? In this image, there is uptake of dye in the basal cisterns. That means there is some inflammatory material present in our, around the midbrain in our basal cisterns. I can call it as basal inflammation exudates. Anybody wants to tell me? Basal exudates. That means there is inflammation in the base of the brain, around the brain stem. What is this typical of? This is typical of tubercular meningitis. So as soon as you hear the word basal exudates in a contrast enhanced CT or MR, please mark the answer as tubercular meningitis. What else can be there in TB meningitis? Tubercular meningitis causes inflammation of the arteries. It causes inflammation of the arteries. We will describe it as endarteritis, leading to infarcts in the basal ganglia. Small infarcts in the middle cerebral artery territory, in the basal ganglia due to end arteritis are known to occur in tubercular meningitis. So the question is, why do you develop infarct in tubercular meningitis? Because of presence of end arteritis. Because of presence of end arteritis. Okay. Now we will do a tough question, then I will tell you the clinical scenario. The first image I am labeling as contrast enhanced image. Second is a diffusion weighted image. What do we see in contrast enhanced image? There is a ring enhancing lesion. If there is ring enhancing lesion, it is telling us there is some inflammation happening in a ring like fashion. But when I see the diffusion weighted MRI in this patient, the lesion is bright. Lesion is bright on diffusion. Okay. Now, before I go on to this again, I am zooming in. I am zooming in to the image that I want you to see. Please see. This is a contrast enhanced image. ये बीच में जहाँ M लिखा है, that is midbrain. Surrounding the midbrain, you should have CSF in the interpedunculaire fossa. उसके आसपास. Now, in this patient, instead of CSF, all around, you can see in this area that I am trying to mark, there is some irregular dye uptake. This is a contrast image. These are called as basal exudates. Okay, inflammation है वहां पे सारा. That is what is taking up the dye because it's all inflamed tissue. That is called as basal exudates. Okay. Now, if a ring enhancing lesion is there, that tells me, ये कह रहा है, if you see a ring enhancing lesion, that tells me that there is some cause here which is causing inflammation surrounding it. Inflammation is causing ring enhancing lesion and there is surrounding edema. But when the inflammation is a war against the enemy. So देखो, there is an enemy in our body, infection, and body has launched a war against it. In the war, sometimes what happens is, some of our soldiers, some of the bacteria, some WBCs will die. So these dead WBCs, these dead bacteria will form the pus. They will form the pus. Pus will be thick and viscous. Pus is a very thick and viscous liquid. So in pus, no movement can happen. So if there is no particle movement, it will be bright on diffusion. So if a ring enhancing lesion has a bright core on diffusion weighted MRI, it tells you it has pus inside. If it has pus inside, it should be a brain abscess. Then that means it's a brain abscess. What is pus? Dead bacteria, dead WBCs in a patient with long-standing inflammation, liquid inside, which is thick and viscous, bright on diffusion, brain abscess. But when will you suspect brain abscess? There should be some source of infection. So what is close to the brain? Sinus, ear. So in ENT you will see, they will say patient with sinusitis and ring enhancing lesion in the brain. Think of abscess. Patient with ear discharge. Previous year's NEET PG question. Remember, ear discharge patient has ring lesion in the brain. What should you suspect? Brain abscess. So abscess will form in the brain from surrounding structures like sinus, like ear discharge. Always keep them in mind. Any other cause of abscess you can think of? Abscess can also happen in the brain in patients who have maybe a congenital heart disease. In a congenital heart disease, if you have a peripheral focus of infection and that passes through a congenital defect in the heart, goes to the brain and causes a septic emboli in the brain, it is possible. So keep in mind the predisposing factors will be either they will write sinusitis, CSOM, ear discharge, sinus infection, congenital heart disease with a ring enhancing lesion in the brain. Think of brain abscess. Okay, one more question for you, beta. Okay. Can you also tell me that ring enhancing lesion could also be metastasis? and metastasis to the brain are particularly common in lung cancer. Particularly common in lung cancer. If they ask you which type, can you name which type of lung cancer is notorious for cerebral metastasis? Which type of lung cancer is notorious for brain metastasis? Answer is small cell cancer. Small cell cancer. Very peculiar, goes to the brain. Very, very peculiar. It is so much likely to spread to the brain that this is one cancer in which we give prophylactic cranial radiotherapy. So which cancer, name one cancer in which we give prophylactic cranial radiotherapy. That means as soon as you diagnose small cell cancer of the lung, you give radiation to the brain. Even if there is no metastasis on MRI, you give radiation prophylactically, because we know it is notorious to spread. There will be microscopic metastasis. So in which cancer we give prophylactic cranial radiotherapy? Small cell cancer of the lung. Anybody? What is the most common site of brain metastasis? What is the most common site of brain metastasis? Gray white matter junction. Most common site of brain metastasis is gray white matter junction. Keep this in mind. Any problem in hematogenous spread, any disease which is coming to the brain via blood, it gets likely to lodge in the gray white matter junction. Very important, because the blood vessel caliber changes from gray matter to white matter, it becomes narrow. So any disease which is coming via blood will lodge at the gray white matter junction. So if this is a previous INI-CT question, brain metastasis most commonly seen in, the answer is gray white matter junction, because they are coming hematogenously. Which lung cancer is notorious for brain spread? Small cell cancer. Okay. Are you clear? Okay. So let me repeat. So what I'm reading here is that brain में हमने बात की थी कि infarct diffusion weighted MRI पे bright होता है. So infarct is bright on diffusion weighted MRI because the ions are not moving. But today I have also added even brain abscess will be bright on diffusion because the pus is thick and viscous, it cannot move. The differentiation is, if it is a ring enhancing lesion, that means there is inflammation, which is bright on diffusion, please mark abscess. Everybody clear? Okay. So my suggestion is we can go forward also if you allow me, or we can continue in the next class also, or whatever you say. I have only a few small things to show, or maybe you can see it in the next class also, it's okay. Okay. So before you go for today, don't forget our ritual. Our ritual of the class is that before you go, we need to do something else. Can you tell me what is it that you want to do? Can you tell me what is it that we need to do? We need to do first we'll do the rapid fire quiz, and then we will do some more signs also, don't worry. Okay. So the time for the rapid fire to charge your batteries. Okay. Let me charge your batteries first. Okay. Let's have that aag laga de. Fastest finger first. Okay. Let's see anybody. Let's see how many of you are recharged or not. White matter is more white than the gray matter. CSF is hypo intense. It is dark. Which MRI image is this? Anybody? White matter is hyper intense. CSF is hypo intense. Which MRI image is this? The answer is T1 weighted MRI. T1, याद है ना? White matter भी white है, CSF dark है. T1 weighted image. T1 weighted image. Very good, everybody. I can see you are all rocking. Investigation of choice for diffuse axonal injury is. Anybody can recall an answer. Diffuse axonal injury, persistent comatose patient after long TE, long TR is same as T2 weighted image. Long TE, long TR is, okay, T2 weighted image. T2 weighted image. Very good, everybody. T2 weighted image. Very good. Okay. Puff of smoke appearance seen in. Puff of smoke appearance seen in. Puff of smoke appearance is seen in Moya disease. Moya disease. Puff of smoke appearance is seen in Moya disease. Please let me know in the chat box. Moya disease. Very good. Contrast material used in MRI. Anybody can recall? Contrast material used, so please slow down the chat a little bit. Contrast material used in MRI is gadolinium. Contrast material used in MRI is gadolinium, which causes T1 shortening. So that is why we see the effect of contrast on T1 weighted MRI. Lipid peak in a brain lesion on MR spectroscopy. What should you suspect? Lipid peak on a brain lesion on MR spectroscopy, you should suspect tuberculoma. Lipid peak on a brain lesion, think of tuberculomas, necrosis. MRCP uses IV contrast, true or false? MRCP IV contrast से करते हैं, true or false? Tell me. Answer is false. MRCP uses heavy T2 weighted images. It does not use any contrast material. It does not use any contrast material. Identify the image shown to you. Identify the image shown to you. Let's see how many of you can rock the show and let me know the answer. Investigation, identify the investigation that you can see here. I can see the energy in your chat also now. Tell me, what is it? Susceptibility weighted MRI. SWI. Susceptibility weighted MRI. Identify the arrow mark structure on the MRI. Identify the arrow mark structure on the MRI. What do you think? ACL. Anterior cruciate ligament. ACL. Anterior cruciate ligament is the answer. Anterior cruciate ligament. Clear? ACL. ACL is the answer, beta. Final question. Identify the arrow marked part of the ventricle. ये कौन सा ventricle है जो pons के पीछे है जो arrow से mark किया मैंने? Okay. Which is the ventricle between cerebellum and pons marked by the arrow? Identify the structure. It is your fourth ventricle. This is your fourth ventricle. This is your fourth ventricle. Everybody clear? Okay. So now I will tell you one important concept. And after that concept, we will decide if we can study for 15-20 minutes more or not. I will tell you one more concept. Okay? Let's see. My question to you is, are you a clock gazer? I will explain to you what is a clock gazer. I am sure many of you in your college must have seen in your administrative block, or whenever you go to a Sarkari office, you go to a office admin block. You will see many people who will be sitting there in the office who will not be ready to do any work and who will keep looking at the clock after every some time and say, 4 kab bajenge? Have you ever seen? Have you ever seen in your life when you go to a admin block or administrative section, you find people who are expressionless, doing nothing, only looking at the clock, 4 kab bajenge? You are there for some work. They are saying 4 kab bajenge. What are these people? Clock gazers. Clock gazers mean that people who are not enjoying what they are doing. Nobody wants to become a clerk. Everybody wants to become Steve Jobs, entrepreneur, scientist, researcher, astronaut, super specialist, doctor, everything. Nobody wants to become a clock gazer. Nobody wants to become a clock gazer. So nobody wants to become a clerk. But then why does somebody become a clock gazer when you are regretting what you are doing, when you are not happy in what you are doing? So my question to all of you is, when you are studying with me, are you a clock gazer or are you wanting to do more out of life? Are you happy learning or not? Are you enjoying your learning process or you are a clock gazer? So my question is, अगर बार पूछोगे कि टाइम कितना रह गया है क्लास में, कुछ गड़बड़ जा रही है भाई. This is not right, because that means you are looking at the clock. Successful people are not looking at the clock at all. Successful people जब काम कर रहे हैं उन्हें टाइम का पता ही नहीं चल रहा. Have you ever heard of this phrase in your school, in your college, कि ये surgeon starts the surgery in morning until night, he forgets about time. Highly successful people, they forget about time because they are not prisoners of their clocks. So my question is, are you a clock gazer or are you following your dreams? Tell me. So I hope you are now clear. So you are not clock gazer. Number 2 question is, to learn better, we need to learn with a childlike enthusiasm. To learn better, we need to learn with a childlike enthusiasm. And the difference between children and old people is, children are happy to learn. Children are always happy to learn the concept and they are able to enjoy what they are doing. So are you a child? Are you an old man? Tell me, are you happy to learn or not? So these are the 2 things. Okay, so these are the 2 things that I wanted to tell you, that stop being a clock gazer, stop being a person who is bound by negativity. Let's become as positive as a child. Children are always enthusiastic to learn, happy to learn. So I'm asking you again a question. Do I have enthusiastic children in my class or not? Yes. So quickly, just 2 lines. Just 2 lines, okay? Just 2 lines before we go. Before we go, because we are not clock gazers, we are people following passion. Not ordinary people don't become doctors. I am telling you, you are not ordinary. Ordinary people don't become medical students. You are a high impact seeker. You want more out of life. And मैं बता रहा हूं, आप थके ही नहीं हो. ऐसा लग रहा है आपको, असली में आप थके नहीं हो, क्योंकि आप ज्यादा चाहते हो जिंदगी से. You are more, you want more out of life. तो उसके लिए 2 बातें. Just 2 things about Parkinson's. Just 2 things before we go today. Just 2 things about Parkinson's radiology. Just 2 things. Number 1, Parkinson's diagnosis is not made in radiologically, it is made clinically. Key thing. Radiology is not used to make a diagnosis of Parkinson's. Diagnosis of Parkinson's is made clinically. But modern radiology has become so good that we are now able to see some changes of Parkinson's on radiology. Can you tell me where will we see the changes? 2 places. Substantia nigra and in the striatum. Are you aware of this? Parkinson's is a problem in, we are just enjoying, we are not studying, just enjoy kar rahe hain. Parkinson's is a problem in nigrostriatal pathway. So we should see the problem in substantia nigra and in the striatum. Okay? Try to see the normal thing. This is how your midbrain looks like. The arrow or pink arrow is at the aqueduct. The white arrows are marking the substantia nigra. So you can see here, this is your substantia nigra. Substantia nigra is black. It is black on MRI, but it has a white part in the center which makes it like a tail. That white part is called as nigrosome 1. Okay, that white part is called as nigrosome 1. So if I now tell you in radiology language, in radiology we like to give examples. Substantia nigra looks like the tail of this bird. It looks like the swallowtail. Substantia nigra looks like the swallowtail on MRI. If you have Parkinson's, the nigrosome 1 is lost, so the swallowtail appearance is lost. Okay, so quickly answer the question. Swallowtail sign is absent in which condition? Parkinson's. But it is not necessary for diagnosis. Diagnosis of Parkinson's is made clinically. Second is a special scan which is called as DAT scan. What is DAT scan? What is DAT scan? Dopamine transporter scan. What is DAT scan? Dopamine transporter scan. uses iodine 123 labeled ioflupane. Normally, if you give iodine 123 labeled ioflupane, it should be taken up by your corpus striatum. So it is taken up by your caudate nucleus, by your putamen, in a comma shape appearance. I am again repeating. If you do a DAT scan, normally the isotope should be taken up by your striatum. It should be taken up by your caudate nucleus and putamen, that is called as comma shaped uptake. In Parkinson's, this area is reduced in size. That is called as, it reduces in size because there is a problem in the striatum, that is called as period like uptake. Period means full stop. So period like uptake. Should I repeat? So Parkinson's. Okay. Okay, Parkinson's, two things. On MRI, Parkinson's will show absent swallowtail appearance, and on DAT scan you will have period like uptake. Normal uptake on DAT scan should be like a comma. Okay. So MRI is not, radiology is not essential to make a diagnosis, but there are some features that you can see on DAT scan, on MRI in Parkinson's. The role of MRI in Parkinson's is actually to diagnose Parkinson's plus syndromes. I will explain it to you. Can you name a disease which is classified as Parkinson's plus, which has midbrain atrophy? Can you name a disease which is classified as Parkinson's plus and shows midbrain atrophy? This is a T2 weighted MRI. I will label it for you, beta, don't worry. This is pons, medulla, cerebellum, midbrain. Now I want all of you to see the midbrain of this patient. Compare the diameter of midbrain, especially the tegmentum anterior part, with pons, with medulla, with spinal cord. Can you see the midbrain is very, very thin? It is atrophied. I will quickly clean it up for you. This is the midbrain of the patient. It has become very, very thin, very, very thin and flat like this. The pons is fat and round. The midbrain in this patient is thin. The medulla is also thick. Only the midbrain is thin. I'm looking at it, continuously looking at it, and it starts to look like a bird to me. Which bird is this? Hummingbird. Hummingbird sign on MRI, seen in. Now can you make a diagnosis from your knowledge? Progressive supranuclear palsy. So MRI in Parkinson's is not really useful, but it is able to tell us if it is a Parkinson's plus disease, like progressive supranuclear palsy. Progressive supranuclear palsy has midbrain atrophy, which looks like a hummingbird. Now what I have learned in life is, there are two kinds of people. People who believe and people who don't believe. So people who don't believe will look at this MRI and say, अरे कोई hummingbird तो है ही नहीं इसके अंदर, पता नहीं क्या कहते हैं, ये बोरिंग एकदम है ही नहीं. But if you look at it with concentration, if you look at it with optimism, with hope, with positivity, the hummingbird will reveal itself to only to people who are positive. And you can see a bird, hummingbird, flying. A beautiful hummingbird. Let's make some colors like this. So it's also called as the penguin sign. But the important thing is, it takes time to reveal the beauty of radiology to you. That is why sometimes I might overshoot the class by 5-10 minutes, but it takes some time to make sure that you realize that progressive supranuclear palsy on MRI shows hummingbird or penguin sign. Everybody clear? Where is the midbrain in this image, beta? Phaeolum, this is the midbrain. Clear, beta? This is the midbrain. And it's so thin. Okay? Abnormally thin. And final part of the class, just the final word. Second Parkinson's plus disorder is called as MSA. MSA is nothing but multi-system atrophy. Two types, MSA-C, MSA-P. PSP was progressive supranuclear palsy. MSA-C is olivopontocerebellar atrophy. MSA type P is putaminal atrophy. ओके एक ही बात पढ़ना, इसमें हमने ज्यादा नहीं है. मल्टी सिस्टम एट्रोफी इज ऑल्सो अ पार्किंसंस प्लस डिसऑर्डर. टाइप सी इज कैरेक्टराइज्ड बाय olive is a medullary nucleus, pons and cerebellar atrophy. MSA-P is putaminal atrophy. I want you to see this image with me. Everybody, orbit, temporal lobe, cerebellum. I want all of you to focus on the cerebellum. Can you see the foliar architecture is very, very prominent? The reason it is so prominent is because cerebellum is thinned out in this patient. What do you have in this patient? Cerebellar atrophy. This large white thing that you see in the center is your fourth ventricle. So because the cerebellum has atrophied, fourth ventricle has become larger. And look at the pons. Everybody now look at the pons. Even the pons is atrophic. Pons is also small. No, it is not the fat rounded thing, it is small. And when the pons atrophies in this disease, in pons you have cruciform fibers which become gliotic. Gliosis means in brain you don't have scarring. In brain we call it gliosis. So you will start to see when you look closely, I will try to remove myself also. When you look closely in the pons, you will see prominent white colored cross in the center of pons. This is called as hot cross bun pons. So in which condition do we see hot cross bun pons? MSA, multi-system atrophy. Which type? Type C. And this is one of the previous JIPMER questions. Same image they have asked in the exam. So role of MRI in Parkinson's is very simple. Parkinson's diagnosis is clinical, but MRI can show absent swallowtail appearance in the midbrain. On DAT scan you will see period-like uptake. Comma-like uptake is normal, period-like uptake is Parkinson's. And we also talked about that hummingbird sign, progressive supranuclear palsy, hot cross bun pons, multi-system atrophy type C. Okay, and you all have spent an extra 10 minutes just to prove to your own self that हम थकने के बाद भी हारते नहीं हैं. It is very important. Whenever you feel tired, whenever you feel like giving up, take some, maybe small break and then come back again. एक बार वापस आएंगे. You will see that you have the ability. You have the ability. You are not an ordinary person. Keep reminding us. You are not ordinary people. Ordinary people don't come so far. Ordinary people do not choose medical profession. You are extraordinary. By the effect of your choices that you have made in your life, you are already extraordinary. Be grateful for the journey that you have already had. Be happy that you are already a high achiever and you are striving to do even better. I wish you all the best. Very, very warm good night. Again today, if you have any queries, any comments, anything you want to tell me about the answers that you did, anything you want to discuss, feel free to send a message to me on Instagram, Sumer Doc. I'll be happy to take a query. And if you are very happy like the child that we saw dancing today in the class, you can share a story of your class or you studying with your mobile phone. Share it on Instagram with me. I'll make it my own story. I wish you all the best. Good night. I'll see you in the next class. In the next class, we will continue with the brain pathologies and then we will go on to chest X-ray. Just like brain, I will spend a lot of time on chest X-ray also. Okay, because I know that is very, very important. I wish you all the best. Love you all. God bless you. Stay positive. Keep rocking.